A warm welcome from Chwani to all our distinguished participants. It is an honor to have 15 African countries in attendance, who are joined by a large contingent from UNICEF. And it's always good to have a UN body contributing to such a critical policy and delivery challenge as the one we are covering today. I'm also pleased that we have colleagues from the Gates Foundation, the WHO, World Bank, African Development Bank, the Clinton Health Access Initiative, and others. Taken together, we probably have around 26 African countries that are present. So welcome everyone. Let me share some thoughts as a contribution to the framing of our dialogue today. Since the first COVID-19 vaccine was administered in Africa, just about 8 months ago, less than 4% of the continent's 1.3 billion inhabitants have been fully vaccinated. This is in sharp contrast to a world average of 30%. When we got together in April this year for a previous dialogue on this topic, there was general consensus that vaccination against COVID-19 was the single most important measure to mitigate against loss of lives and further economic disruption. It is estimated that for every month without a vaccine, the African continent loses around 13.8 billion US in GDP. Now, this is taken from Relief Web publication in 2021. In April, before most countries had begun their vaccination programs in earnest, we considered, one, the early trends in budgeting for the vaccine across the continent. Our ministries of finance and health can work together to ensure vaccination programs are adequately covered in the budget. And three, how to ensure the different elements of the PFM system are sufficiently flexible and reliable to facilitate vaccine program implementation. And I'm sure all of us on this call know that PFM refers to Public Finance Management System. We also shared our collective knowledge of the cost and benefits of different financing options for vaccines. How procurement can be undertaken in an emergency and still ensure efficiency and accountability, and how countries can cost the rollout, utilize the private sector and NPOs, and ensure funds flow efficiently to service delivery centers. So suffice to say that our April dialogue was jam-packed with important discussions and presentations. If we are to rapidly scale up COVID-19 vaccine programs in Africa, we will need sustained collaboration between health and finance officials in the planning, budgeting, and implementation. Political commitment and the domestic resourcing will also be crucial. I was reading something by Dr. Fiona Atuhebwe from the WHO, where she reminded listeners that when the Republic of Cote d'Ivoire applied to receive vaccines from COVAX, that, and as we know, some of these vaccines require ultra-cold storage, the government of Cote d'Ivoire was willing to send the presidential jet to fetch the kit. She says that this is the kind of commitment that our countries need. And I also think that it is a good use of a presidential jet. The recognition of the importance of this is what brings us here today. During this 2-day peer learning and exchange event, we will provide for health finance experts and practitioners from these 26 African countries to critically reflect on the current state of their COVID-19 vaccine programs and the effectiveness of collaboration between the Ministry of Finance and the Ministries of Health, and learn from peer countries and experts about financing requirements for the vaccine, procurement and distribution successes and challenges, and how vaccine programs have been funded from domestic resources will also be articulated during this dialogue. So if I was to frame today's dialogue, it will be through the following three questions. The first is, what funds and financing are required for the COVID-19 vaccine program? Two, how do we improve efficiency, especially in the procurement and distribution of the vaccine? And a third question that is particularly pertinent for Africa is, what are the arguments for and against prioritizing the COVID-19 vaccine against competing needs and within increasingly constrained fiscal environments? And then finally, I want to encourage all of you to actively share your perspectives with your peers from other countries and institutions. And while our country context may differ, we are facing, and I think we all recognize this, a common threat. And therefore sharing our challenges and possible solutions will be invaluable. It will also facilitate the development or the building of a more collaborative Africa-wide approach in most cost-effectively procuring the COVID-19 vaccine and eradicating the virus in Africa and globally. Thank you very much.
Thanks so much, Neil. That was great. And before anyone gets worried, this is only a one-day event. I know Neil mentioned the 2-day, but only one day for this time. Okay, great. So we'll move on to my presentation now. So I'm Danielle Cerebro. I lead our health financing work at Cadbury, and we've been looking closely at the COVID response and the public finance implications, and looking at vaccine financing, procurement, and distribution. So in this presentation, I'll briefly run you through the program for today. Then I'll go through some of the key messages from the April event. That's particularly for anyone who wasn't able to attend that event. We'll look at where we are now in terms of vaccine development and vaccine financing, and some of the key developments that we've observed in terms of vaccine financing, procurement, and distribution since April. Next slide, please. Thank you. So just briefly on the program, after this session, we'll go to session 2, where we'll hear from the World Bank in terms of costing Africa's COVID-19 vaccination financing needs and the gap there. We'll hear from Caitlin and Sarah. Then we'll hear in response to that presentation from Dr. Malukan Johannes from the Ministry of Health in Ethiopia. We'll then have a short comfort break of 10 minutes and move on to session 3, where we'll hear from UNICEF and some of the key challenges in procurement and distribution on the continent. That'll be presented by Sam and Bob from UNICEF, and Khadija and Mark from the Department of Health and the National Treasury, respectively, will comment on that presentation. And I'm hoping we've allowed a lot of time for Q&A in each of these sessions. So I'm hoping that people will ask questions and also provide your own country experience and respond to our presentations. Then we have another very short comfort break of 5 minutes, and then we look at reprioritizing budget towards COVID-19 vaccination programs. We'll hear there from Claire, who's written an excellent case study for us on reallocating resources to the COVID-19 response and what that means for vaccination programs. And then we'll hear from DG Ben Akabuezi and from Nigeria, and Andrew Blasey from the OECD, before wrapping up with closing comments from Neil. Next slide, please. So the key messages from our April event. So as Neil said, we reiterated that vaccination against COVID-19 is the most efficient and effective measure to mitigate against loss of lives and further economic disruption. We also discussed that domestic resources are critical for closing the financing gap for COVID-19 vaccination, and that this is particularly true for the operational costs. We noted that allocating these through budget documents will ensure that African governments signal commitment to the rest of the world and catalyze external support. And of course, this is just a basic transparency and accountability requirement. We also noted that limited information on how countries are financing, budgeting, and procuring the COVID-19 vaccination is limiting opportunities for peer exchange like this, and it's also limiting cross-continental unity. We noted that the uncertainties associated with COVID-19 vaccination programs mean that unusual degrees of budgetary flexibility is required, and we need even greater transparency and accountability than in normal times. We also noted that these uncertainties require shorter feedback loops, more frequent meetings, and enhanced coordination and dialogue between ministries of finance and health. And that's what we're aiming to facilitate today. We noted that variance in vaccine prices and lack of price transparency has further contributed to costing uncertainties, and that greater vaccine price transparency is needed and can come about through regional unity. We've seen movements towards that over the past few months. And we noted finally that not budgeting timelessly and relying on rushed reprioritization exercises may lead to crowding out of priority expenditures, and including health and other vaccine programs. Next slide, please. So looking at where we are now, so as Neil mentioned, we're at 4% of population vaccinated. I think we would have all hoped in April that we would have been quite a lot further along with a worldwide average of 30%. Some countries, you can the Seychelles, an island, Mauritius, Morocco are already above 40%, but the rest of us aren't doing very well, and making events like this even more important. Next slide, please. So this information shows us how many vaccines have not yet been administered, but have been secured and or expected to be delivered. So this is from the IMF WHO COVID-19 vaccine supply tracker. It's a really comprehensive database established by the IMF and WHO that's tracking the number of vaccine courses secured by countries through different channels. So it's bilateral agreements, donations for other countries, COVAX, other multilateral agreements. And here we see that a vaccine course is essentially two doses where it's required, and that will be one course. And then for those that J&J that only require one dose equals one course. But what we see here is that most countries are in the orange zone, which is that 30% of their population will be covered by vaccine deals that have already been signed. So not that those are already in the country, but that there are those deals that have already been signed. Financing has been made available, or pooled procurement mechanisms are in place. Next slide, please. Thank you. So now this is also from the IMF WHO vaccine supply tracker, and it's a breakdown of the sources of these secured vaccine courses, again by percentage of population. And you can see the biggest chunk is other sources, because that is that's AVAT, that's the African Vaccine Acquisition Task Force by the AU. We have the COVAX cost sharing mechanism, which isn't as relevant in Africa. And then these are just bilateral purchases secured by World Bank financing. As we'll discuss later, there's already 20 billion World Bank financing that's being made available for vaccine financing. Then we have a smaller portion of COVAX advanced market commitment or self-financing participants. And then we have COVAX donations. So that's on top of countries that are self-financing, you add those two together. And then you have donations which are bilateral donations. So that's China or India giving directly to a country. So that's the breakdown. And you will send this out, so obviously you can have a closer look at it, and you can also go, I've hot linked the source, so you can go there and look around. But if you can move to the next slide, please. Thank you. Great. So we're going to move on to some of the key developments that we've observed since our first event. And the first one that we've observed is that there's now a clearer estimate of the financing requirements and the gaps. So when we spoke in April, there really wasn't much insight into how much money was required per country or on aggregate. And we just didn't know what the costs comprised of. So in May, this is what our colleagues from the World Bank will share with us shortly. Calculations were released for Sub-Saharan Africa in terms of the COVID-19 vaccination financing gaps. They provide a detailed breakdown there. And the estimate is that 12.5 billion will be required to vaccinate 70% of the continent. And that's without booster doses. So we'll hear more about that shortly. We've also seen more countries using the COVID vaccine introduction tool by the WHO, and that 95% of countries have completed a national vaccination plan. But I've highlighted this because I'm hoping that colleagues from the WHO can let us know if there's any update in terms of the number of countries that have used the civic tool. The last that I saw, I think, was July, and there were 13 countries that had used it. It would be good to know if more are making use of it, and even some of the obstacles there. We tried to discuss that in our first workshop. And then finally, another way that we're getting better insight into the financing requirements is this WHO Africa COVID-19 vaccine dashboard. And also I've included the link there, so you can go check that out. This covers all aspects of the vaccination programs across countries, and then 27 countries, for 27 African countries, you can see the financing requirements for operations, and that's broken down even further. So incredibly useful tool. Definitely recommend going to check that out. But I guess what's alarming here is how much is still required versus what's been made available. But yeah, so that's just so we have a clear estimate of financing requirements and gaps. That's the first observation. We can move to the next slide, please. Great. So the next development we've seen since April is that more vaccine programs and vaccine costs are being included in national budget documents. So at our previous event in April, we pointed out that most governments in Africa hadn't yet budgeted for the vaccines, and we were all quite concerned about that. Obviously, there are many reasons why these programs won't have been budgeted for or included in budget documents. I think some governments must assume that international support would fully cover their programs. We're now seeing that that won't be the case. And some unofficially expressed that there's competing priorities, and when the numbers are as low as they are, there may not necessarily be a justifiable case for allocating scarce resources in that way. Also, obviously, some spending is just happening off budget and is going to continue to happen off budget. But our latest round of data collection for the COVID-19 Public Finance Response Monitor, which you should definitely all look at, that's where we're tracking how countries are responding to the crisis. And we can put the link up now. So that the latest data collected does paint a more promising picture of how African governments are making provision for COVID-19 vaccination programs through their budgets. And there's also some indication that countries are allocating more of their own resources. So we included in the room document that we sent around a table that captures information included in the monitor for 18 countries. And what I've just included here is essentially the amount allocated per capita for vaccines in the budget. And what's very clear is that these amounts vary hugely across countries that we've captured. And this obviously represents that some countries are allocating funds for the entire program, including operational costs, and some are just allocating for operational costs and not for the actual purchase of the vaccine. But yeah, thanks Priya for putting that in the chat box. Next slide, please. So the next development that we've seen since April is more investment in local manufacturing capacity. And this is obviously a very important step for self-sufficiency of health systems and vaccine programs on the continent. So we're quite excited about this. In South Africa, for example, we've seen that there's been a $710 million financing package for Aspen Pharmacare. And there they're filling and finishing, which is essentially packaging imported vaccine substances. And they've already started producing, and there's 500 million J&J doses expected by end of 2022. In Senegal, we've seen that with support from the United States and Europe, they're currently building a $200 million COVID-19 vaccine manufacturing facility. And this facility will actually represent the first on the continent to manufacture the substance of the vaccines and also going about filling and finishing. Egypt also has a planned capacity of 1 billion vaccines annually, producing Chinese Sinovac. But we're still seeing that the emphasis remains on fill and finishing capacity rather than necessarily at full vaccine substance manufacturing and technology transfer. So that's, I mean, something that we need to start investing in and thinking more about. Thank you. Next slide. So the next development is that we're seeing different challenges emerging in progress in pool procurement and amongst international commitments. So we know that COVAX aimed to deliver 620 million vaccine doses by the end of this year. And there's been, due to export bans, I mean, we saw what happened in India, challenges in scaling up production, regulatory delays, they're now only expected to deliver 470 million. And that's only enough to vaccinate just 17% of our populations. So I guess, again, that re-emphasizes the importance of domestic resource allocation. An important step was that the IMF, the WTO, and World Health Organization came together to call for a $50 billion in new public spending to accelerate COVID vaccine in low and middle income countries, with at least 35 billion of this to come as grants for these countries to purchase vaccines and build up their health systems. So this is a call, it hasn't yet been committed, and it's our hope that this comes to fruition, but whether it does, we don't know yet. We also have seen that the World Bank is expanding its financing for COVID-19 vaccines to $20 billion over the next 18 months. So this is from an original 12 billion announced earlier. They've now added another $8 billion. However, only by September, only 1.8 billion had been committed to African countries. So we might hear from our World Bank colleagues how that's going and some of the challenges in terms of releasing this finance. We also seen that the United States has announced that it'll provide 1.1 billion vaccine doses through COVAX, and Team Europe has committed to share 500 million doses by mid-2022. The big issue here is the timelines. We're seeing that these are really delayed and keep being delayed further as countries start prioritizing their own populations and start going forward with booster doses. So when these are going to be forthcoming, we don't know. These commitments have been made, but the timeline is just very, very unclear. Yeah, we can go to the next slide. Thank you. I think my numbering was wrong. This is development number 5. But we're seeing more and more demand side constraints and distribution challenges. So this is something I think we were already aware of in April. We did discuss concerns around vaccine hesitancy and how much more needs to be invested in the uptake and in the demand and sensitization, and just ensuring that money gets to delivery units. But the WHO has pointed out that 26 countries on the continent have used less than half of their COVID-19 vaccine doses. So obviously this is a huge concern. We know that supply is a concern, but now countries aren't even using what they've got. And there's multiple reasons for this. Countries may have allocated enough funds to cover the costs of the first batch of vaccines and potentially to cover health workers, but there's a funding shortfall towards as the number of people rises to be reached and as there's more peripheral areas to be reached. Obviously, there's a lot more expense as you go away from the major cities. So in Ghana, which has done very, very well in terms of its vaccination program and was the first to qualify for COVAX delivery, we've seen that not enough trained staff were available to deliver the second shipment of COVID-19 vaccines from COVAX. And there also wasn't enough funding made available to procure equipment such as masks and cotton wool. In the Democratic Republic of the Congo, 75% of doses received from COVAX had to be sent back because they were going to expire, and those are redistributed to other African countries. And what we're seeing is that there's a really significant gap for operational costs, and development partners aren't necessarily funding that aspect, and that's for countries to finance. And this needs to go towards developing better data and tracking systems, improving cold chains, training healthcare workers, and sensitizing communities and building trust. And this is also from the World Bank that tells us that only 59% of African countries have developed plans to train vaccinators, and less than 50% have a plan in place to generate public confidence, trust, and demand for the vaccines. So thank you very much. That's the end of my presentation. And I've done it with 3 minutes to spare, so well done to me. But yes, I think we can now call on the World Bank to start us off for our next session. I'm hoping they're ready with us because I'm running a bit ahead of schedule. Kate, are you around? Thanks so much. So this session is essentially going to be discussing some of the financing estimates that the World Bank has done. And then we're going to ask countries to come in and reflect on how these costing estimates align or don't align with at a country level, and just some of the challenges with sourcing this financing. Thanks, Kate and Sarah, over to you. Thanks for joining so early.
Good morning and good afternoon, everyone. My name is Kate Yu from the World Bank. Thank you for the opportunity to speak today on such a pressing and unprecedented challenge we are going through today. So today, me and Sarah will be presenting on the costing of COVID-19 vaccination financing needs in Sub-Saharan Africa. And I believe you all by now are COVID and or vaccination experts, almost living but for 2 years now. But I hope this presentation will provide you some guidance and clarity on the methodology and assumptions that you've been seeing from us and other international communities. Next slide, please. So today, here's the agenda. We'll first go over the objectives and overview of the costing estimates for vaccination financing needs in the region. We'll also look at the fiscal burden of vaccination rollout. And Sarah, my colleague from the World Bank, will provide the overview of the World Bank COVID-19 vaccination response. Next slide, please. So we have 3 objectives for today's presentation. So first, after the presentation, we hope that you understand the methodology and assumptions taken for vaccination rollout estimation in Sub-Saharan Africa. And second, we hope that you understand the fiscal burden of vaccination in both absolute and relative terms. And last but not least, you will understand how the World Bank is assisting countries to finance COVID-19 vaccination rollout. Next slide, please. So for the costing estimates, we'll first review the indicative costing assumptions, and with the assumptions taken, we'll provide the estimates of the vaccination rollout in the region. But please note that with the caveat that some of the assumptions we'll be discussing today are deemed to change. Next slide, please. So as Daniel mentioned earlier today, in May 2021, our team has estimated that the region needs approximately $12.5 billion to vaccinate 70% of the population in 48 countries, Sub-Saharan Africa. However, as some of you may know, there has been some changes in assumptions during this period since May, when we have done the initial exercise. So we use the assumptions based on the best available data and resources at that time. And please note that this costing estimate is and will be an iterative exercise. So this costing exercise we took in May was a regional top-down initiative to inform project planning. But of course, we work with countries closely to compare with other costs derived from the WHO Civic tool that you may all well know by now. And in fact, in countries where the World Bank model has been used and Civic has been used, the costs end up being very similar. So the biggest change that we had since May was a COVAX subsidy has increased from 20% and now 30% with an additional 7% doses from donors. And so in total, it sums up to be around 37% subsidy for AMC countries. The coverage subsidy almost doubled from 20 to 37%. Also, we expect that the unit cost estimates will change over time. However, these changes have not been reflected in our costing estimates that we will be presenting today. But happy to update once we have more concrete examples on the assumptions. So with the new assumptions of 37% coverage, we have seen a decline of financing needs of approximately 10 billion from 70% of the population in the region for the next 2 years. And this will be further discussed in detail in the next few slides. Next slide, please. So just to give you a better idea of what it costs to vaccinate one person, and these are all ballpark estimates, which are not definitive, but I'll review the methodology in getting these numbers. So how much does it cost to vaccinate one person? We estimated that it would cost between 18 to 19 USD to fully vaccinate one person in AMC countries and approximately $27 to $29 in self-financing non-AMC countries. And this is without the subsidy that we have discussed earlier. So what are the cost components for vaccination rollout? First, the average cost per dose, if you see on the most left-hand side, the average cost for vaccine in AMC countries is approximately $7 per dose, which includes syringes, safety boxes, transportation to the country, and around $10.55 for self-financing countries. The second column is just the 2 doses per person. And the transportation cost on the third column is already included in the 7 and 10.55 per dose. And now let's look at the fourth column. This is the average for service delivery, which is a global estimate based on the exercise conducted by our COVAX costing group, as many of you are part of today, including Gavi, UNICEF, WHO, BMGF, Harvard, and ThinkWell. It's based on the mix of in-country costing studies synthesis of global literature review. These costs excludes the capital investment and labor. The estimates can be revised in country costing studies. In the fifth column, we see the cost of investing in climate change cold chain, which is estimated to be approximately 20% of the service delivery and supply chain cost. And this estimate is actually derived from the energy and extractive global practice at the World Bank and are on a global basis, where it assumed that most sub-Saharan African countries do not have well-equipped cold chain in countries' health system. And last but not least, this cost does not include healthcare worker salaries. And just to note that WHO strategy have used a higher figure for deployment, but this is because they are factoring in the HR cost and the surge, and which is one of the components included in the civic tool. Next slide, please. So now that we have reviewed the methodology and components of vaccination cost, so let's look into the estimates of vaccination rollout in sub-Saharan Africa. Next slide, please. Thank you. So using an indicative estimate of vaccination costing, we estimated that the sub-Saharan African region will require more than $10 billion to vaccinate 70% of the population, which is shown in the most right-hand side of the box. And 70% is actually the new target of the African Union, which has been most recently updated. I believe it was 2 weeks ago, September 14th, that it was announced. And it is also the global target. The 10 billion includes a 37% subsidy received for AMC countries. If you look at the most left-hand side, it is the cost to vaccinate 20%, which includes the healthcare workers and the most vulnerable population, including those with comorbidities and elderlies and other groups defined by each country. And this will require approximately $1.3 billion for the region. And in the middle, to target 60% of the population in the region, which was actually the old target of the African Union, will cost $7.7 billion. Next slide, please. So this slide is the breakdown by cost components, such as vaccine, supply chain, climate change, cold chain, supply chain, service delivery by different scenarios. And in this case, targets. So these different bars here means different scenarios with different coverage targets of 20%, 40%, 60%, and 70% that we've discussed before. And the height of the left side graph means the amount of vaccination cost. And we again see the fourth bar on the left side graph totals up to be approximately $10 billion. And on the right-hand side of the graph shows the distribution of cost components. And we see that the majority of the costs are driven by vaccines. We see that the first two bars, as we see less for the two first bars, as the 37% of the subsidized for AMC countries. Next slide, please. Okay. So now let's move to see what it means to the fiscal burden due to the vaccination rollout in sub-Saharan Africa. Next slide, please. So as we have mentioned previously, we know that to cover 70% of the population in the region will cost approximately $10 billion with the 37 subsidy on vaccines. And what does this mean in relative terms to population, GDP, and also government health spending? So we see that it will cost approximately $15.6 per capita, which has been reduced due to the additional subsidy that we have included in the estimate. As we have seen before, without the subsidy, it will vary approximately $18 to $29 per person, but now it's approximately $15, which has been reduced significantly. And if you look at the shares of GDP is approximately 1%, And the vaccination per capita as a share of government health spending per capita is approximately 123%, which means that the vaccination cost per capita is 1.23 times greater than the government health spending per capita for the region on average. And as you can see on the graph on the left, we see wide variations among countries in sub-Saharan Africa, where the trend seems to be that the poor countries in the region have a higher fiscal burden compared to the richer countries or the self-financing countries in the region. So for instance, South Sudan, if you see on the left top corner, and the Cameroon, vaccination costs per capita are approximately 5 times more than the government expenditure on health per capita, which seems to be insurmountable. And most likely these government would need support to roll out the vaccines and the vaccination to reach the promised target. Next slide, please. So a recent World Bank report has been published around 2 weeks ago or a week ago, and many of you may have seen it. And the study shows that the government spending on health will fall short of pre-COVID trends globally and also in sub-Saharan Africa. As you can see on the graph on the left, this is a projected per capita government health spending comparing the pre-COVID trends, which is pro-health spending scenario. And we're also comparing that to the current projections with COVID, which is a constant health prioritization trend. And the pre-COVID trend is the blue line, and the post-COVID projection is the orange line. And we can see that the per capita government spending is expected to drop and remain below the pre-COVID-19 trends levels in 2026 for the region. And the gap, as you can see on the graph, gets only higher. And also the projections from the report also validates our finding from the last slide, where the report suggests that the majority of sub-Saharan African countries will be unable to finance their country's share of the COVID-19 vaccine rollout. And to keep their health spending growing at pre-pandemic rates, government of sub-Saharan African countries will have to increase the share of their spending on health from 9.4% pre-COVID levels to 13.3% in 2026. Thus, without bold choices to increase the priority given to health, the per capita government health spending will remain below 2019 levels and will further fall in many of these sub-Saharan African countries, with the poorest hitting the hardest. This is why it is critical to have coordinated global action to accelerate development assistance for health in a very collaborative and efficient way. So now my colleague, Sarah, you may well know, will discuss the efforts and the role of World Bank COVID-19 and vaccination response. Over to you, Sarah.
Thanks, Caitlin. Hello, everybody. Good morning, good afternoon, good evening, wherever you are. Thanks so much. Next slide, please. I'm just going to give you an overview of some of the recent developments, I guess, since April. And Danielle has mentioned some of them, so we can be really quick going through these. But basically, as countries are moving to meet the financing needs, the dire financing needs, the World Bank has set up a $20 billion facility to help developing countries purchase vaccines, set up vaccination systems, and then move quickly to vaccinate their population. And we know that more than half of these projects approved are in Africa, with many more in the pipeline. So this changes regularly, and you can find the details on our website. So our financing continues to be demand driven. It's based on country needs, grounded in our longstanding support. So it's part of that relationship we have with the countries. And the specific allocation will really reflect country circumstances based on the evolving vaccine prices and deployment challenges. So as of now, globally, 4.7 billion has been approved. And Danielle mentioned that in Africa, it's just under 2 billion. So again, a couple of these projects would be added. So it's just under 2 billion and changing because of the number of projects in the pipeline. So so we hope that this financing signals that really the country should be able to take advantage of this to fill the financing gap. And then the impact going forward, we've really worked since April to complete some of these arrangements with COVAX and AVAT. So really partnering with COVAX and AVAT to provide vaccines that will enter into agreements that would provide the security to both COVAX and AVAT, but would also respect the vaccine preferences for countries. And then through IFC, our private sector development arm, we're making $4 billion available to increase the supply and production of vaccines as well as PPE, and unlocking some of the supply bottlenecks in emerging markets. To a lesser extent, we're facilitating bilateral contracts where necessary, but as you can see from the graphs that Danielle, in Africa, this is a very, very low share of the overall vaccine, the total vaccines procured. And then countries, as I mentioned, this is really demand-based. So how it is allocated is up to the countries. And I will say what's in the project papers is that can change. So right now, as of September, there's vaccines account for almost 60%. And then 42% is deployment and health system strengthening. Oh, sorry, it should have been the next slide. Go ahead, please. Yes. So yeah, we can go ahead. Okay, so what does this mean? So we've been focusing on costing, and what Caitlin presented was really helpful for countries that are preparing their bank operations and wanting to know roughly what is it going to cost. Now we recognize that that is not the only costing exercise that's happening. And we often, when we know that a country is doing, say, using the civic model, we would work with partners and government to understand the specific cost, and that's more of a bottom-up exercise. So we recognize that this was, kind of standard methodology that changes. So for example, we're hearing about UCC. I mean, if the new Pfizer doses do not require the UCC, then that obviously changes the cost. If the vaccine price goes down, it changes the cost. So all of these factors that all of you know. But now I think where our comparative advantage is with countries is really to discuss the financing, how we can actually prioritize the financing and allocate through various sources. So we know that COVID vaccine is not just a health intervention, it's also an economic stimulus intervention. Given externalities, financing for COVID vaccine should come from government and public resources. That was mentioned earlier, and I think this group would agree with that. Given the challenges of public financing for health, both pre-crisis as well as due to COVID-19's economic impact, countries are facing this challenge, and really the vaccine is the best way to mitigate. And it was mentioned that it's the most efficient way to mitigate the impact. So the World Bank will continue working with countries to explore a menu of options: external financing, raising new revenues, additional borrowing, debt restructuring, reprioritization, and also increasing efficiency. I just wanted to mention the dashboard, and I see that others are using it in CABRI, but this is the work that the task force, the multilateral task force, is doing. And the key functions of that task force are really to help with financing, trade, advocacy, delivery, and manufacturing. And you can use much of the data there. Some of it is also from our World in Data, but it's quite useful to see what has been committed by countries. And that can give you a sense of really where is the gap in terms of getting countries to the targets of 67% or 70%. So in closing, I would just like to summarize. So only with additional resources will Sub-Saharan Africa be able to, or at the African continent, be able to bridge the health financing gap to meet vaccination needs. Countries are also faced with other priorities. And we know that, investing in vaccination, we don't want it to come at the cost of essential services and human capital. And so we need to return to the path towards UHC. Countries will need to mobilize more funding through grants and concessional financing to meet vaccination needs, that's clear. And closing the financing gaps will require strong coordination with countries and partners, drawing on the expertise of respective institutions. So thank you very much.
Thanks, Sarah. Thanks, Kate. That was great. I'm going to call on Dr. Malukan from Ethiopia to respond to this presentation. And then we can get to the Q&A. I'm not seeing any questions being posted yet. But yeah, let's hear from Dr. Malukan, and then if you could just look in the chat at everyone else and just see if that sparks any thought for you to come in after Dr. Malukan is done and share your experiences with us in a similar way to what Dr. Malukan is doing. Over to you. Thank you.
So, hello, Daniel.
Hi, Dr. Malukan, I can hear you well. Thank you.
Yes. So, shall I expect somebody to ask, or shall I directly go to addressing some of the already the provided questions that are
go straight ahead. If you, I mean, based on the questions I sent you already, or any experience that you want to share from your side, that'd be great.
Yeah, okay. Thank you, Daniel. I mean, first and foremost, I would like to thank Catalina and Sarah, which was really a very, very excellent and informative presentation, because I think it really took us back to the challenges we were through while we are doing the the costing exercise. So it really summarizes the whole issues in a very few slides. So it was really a very, very excellent presentation. So I would like to thank those two presenters. Of course, the other presenters too. I think with regard to the questions that are already forwarded, it is true that when we do this costing exercise, there were a number of challenges actually. Some of the challenges are actually, most of the experts, even though they do have, a lot of experience in doing, a similar costing exercise during the campaigns, routine immunizations, the demo projects. But in any case, COVID was, a peculiar and a unique scenario on the assumptions and on the number of, issues that we were going through. So when we see the total costs of COVID-19 for addressing 20% of the total population, which Ethiopia, as it's a very big country, we are estimated to have more than 118 million population. So by extrapolation, 20% means at least it's more than 21 or 20 million population. So the major costs that were actually considered were actually the vaccine cost, delivery costs, and health system strengthening cost. So at that time, there was a debate regarding the health system strengthening, because COVID was considered one of the opportunity basically to provide strengthening for the routine immunization. So because of that, the health system strengthening cost was actually a little bit exaggerated, but in any case, the total cost was actually, it was like 354 million, to address 22% of the population. But here, there were additional costs that are already included with the discussion with the World Bank, and these costs are primarily basically building some of the vaccine laboratories, which are very, very demanding in terms of costs. So because of that, the cost was actually inflated. But when we deduct, the health system, a bold and significant costs, then the cost per capita is actually significantly reduced, between $10 per individual up to some $15 or $18 per individual, which is exactly similar with the way that was presented by Sarah. So that was the issue, but again, thanks to the World Bank team, the team in Ethiopia, they were also, it was presented with another tools which really basically takes into consideration the vaccine cost, the vaccine delivery cost, the very important, the health system strengthening cost, the population coverage, doses required, wastage rate, and the number of, actually assumptions. And based on that, we actually refined, those costs. And, as Sarah was presented, actually, Ethiopia was actually, in between of, not actually seen as an outlier of, when it was actually presented on the graph. I think there were actually some challenges actually. So with this exercise, there were costs that are already missed. There is no doubt on that. But most importantly, the most important issue was actually, no one has anticipated, the challenge that we were actually facing now. No one has anticipated, the global vaccine shortage. Because of that, basically, our operational efficiency was significantly decreased. People were actually to vaccinate, the 20 million in a very, very short period of time. Like maximum of like 1 month or 45 days, because Ethiopia has, a very good experience of vaccinating 50 million children basically within a matter of 2 weeks when we do catch-up campaigns on measles. So the people who were actually doing those exercises were basically gauging, calibrating their thinking with the campaign that we were doing. So at the end of the day, basically, as the global vaccine shortage was one of the very critical challenge which really affected the operational efficiency. The other issues were actually the issue of vaccine hesitancy, because of the extended period for vaccine delivery as a result of the global vaccine shortage. Then through time, people have actually become hesitant, and the misinformation, the disinformation, and everything was actually circulated massively via the social media. And at the end of the day, people were actually becoming very, very, very resistant to the vaccine. So because of that, again, our operational efficiencies and everything was actually decreased. And the issue of basically, it was actually perfectly, discussed by the first presenter, the issue of ultra cold chain. Basically, that was also another issue. And because of the, those ultra cold chain demanding vaccines, then countries has to actually, somehow mobilize additional resources for Pfizer and Moderna. So that is also, some of the best, learnings that we were actually doing. The other issues is actually, as we go through the implementation process, basically, then most of the countries have learned the strategic focus area where they can actually optimize the vaccine coverage. So these are what we call the leadership management coordination, which is really very important, because at the end of the day, COVID-19 vaccines, they have to have a leadership champion. They have to have community leaders. They have to champion those vaccine programs. And then all the leadership all the way from the national up to the lower district and the lower levels were also very important. So that by itself was another cost. And data quality became to the picture, which is really very, very important basically to make informative decisions. So the issue of basically surveillance, the issue of the variant issues, and then the issue of basically the data quality issues, and on basically on the vaccine certification, it's all basically another cost issues basically we were actually learning through the process. And because the communication, additional communication, support message and everything. So because of this, I don't think basically the costing exercise that we did at the beginning really addresses those challenges that we face while we are on the journey. So regarding the source of financing, of course, World Bank, as you all know, the major source of financing, Gavi, COVAX, basically the COVID delivery support, with other domestic resources were there, and partners commitment, basically, because already in the costing exercise, there was one column which says basically partners commitment. So partners were actually committing. So so these are actually the source of financing. With regard to the different costing exercises, it was clearly said that we were trying actually to get bottom and micro planning exercises to estimate basically the amount of costs at the end of the day by the time when it is prorated at the national level. So micro planning was one of the sources, but as people as you go to downward, then there is kind of expectations, and they tend to inflate those costs. But if you get those costs, it's really very important. Then by the time when you disburse, when you send the costs, then it will be very easy, basically, if that's accurate. So just we use it basically, to cross-check, some of the costs that we did. And we have used, the WHO costing tool. And there was also one, costing tool, Excel-based, that came all the way from the World Bank. We also basically used track. And then at the beginning, actually, we were using, just preformed table via the Excel. So these were the different tools that we were using. So all in all, what we have learned is basically, still there could be a missed costs, taking into account the different challenges that different countries are facing, the global vaccine shortage issue, or the vaccine hesitancy, all the vaccine delivery challenges, and the different types of vaccines that are coming from the different sources. So because of this, basically, training has to be, at least refresher training has to be given when you actually introduce a new vaccines, a new COVID-19 vaccines. So primarily you may introduce an AstraZeneca vaccine, which is a 2-dose. Then as soon as you introduce a Johnson & Johnson, then definitely, basically, at a lower level, people has to well aware, all, the vaccine attributes or the cold chain requirements and the delivery models and everything. Then you have to actually, train. When you bring Sinopharm, the same, because even though there are 2-dose vaccines, but the dose interval is actually different, between the AstraZeneca vaccines and Sinopharm. So this by itself actually incurs costs. So these were actually some of the issues that I would like to address, but I'm more than happy basically to respond from any questions that can be raised from the participants. So over, Daniel, thank you very much.
Thank you so much, Dr. Malukan. That was great. I'm actually going to hand it over back to Kate and Sarah, just if they have anything to respond to you about. Otherwise, you can open the floor, or I can ask some questions. I have a bunch. So, and there's also a few in the chat.
Thank you, Malukan. This is really, really, really helpful to hear about the realities on the ground. So as you can see, I mean, the costing work that Caitlin presented, this was most countries that were working with clients to prepare a project with bank financing would use this to get a ballpark figure of what it would, what was needed from the IDA or IBRD allocation. And so really, we recognize the limitations of that top-down costing. At the same time, it was quite useful for engaging and having a discussion. What I think was just described is an amazing opportunity to use the costing as a planning and prioritization tool. So really thinking what is needed, understanding, how can we do more with less, increase efficiency, and the other thing is alignment. So I know several countries, because when they're doing the costing and other donors are around the table with the government, that's an opportunity to say, okay, we can, this donor can finance this and this can align with the government's plan. So I think you articulated that process very well. And I don't think I have anything else, but I don't know if my colleague Caitlin wants to say anything. Thanks.
Thanks, Sarah, and thank you very much, Dr. Desta. That was a very informative discussion. Just to respond to and just to add on the uncertainties and assumptions, and we recognize there are uncertainties with these costing pooled for the World Bank, or it could be civic, and it has been changing quite frequently due to its nature. So depending on the assumptions that we take for the costing, the estimate will vary. However, presenting that certain assumptions very clearly and the cost components of what they are would be key. Just wanted to add that. Thank you.
If I could just add one more thing, because I've seen, costing is a hot topic always on vaccines. And I think people who are not involved in costing tend to throw numbers around and then compare them and say, well, why is this group saying $3.30 versus $1.97 for deployment? And it really depends. We need to be clear about what's behind that. And there's different purposes, obviously. There's costing for advocacy, there's costing for planning, but we need to be really clear with countries when we're presenting this data. So I think it's more important to know what is behind that, but then also, are we costing to a gold standard, or are we costing to the reality? So as you can see, that the paper that Caitlin presented, it's called the Double Shock, Double Recovery paper, and you can find it online, talking about the realities of countries' financing situations. And how 55 countries will have negative growth. That's a case where our country is going to be, it's a prioritization. So will they be trying to fill the gap to cost to absolutely everything they need, or will they be taking an approach where they're prioritizing? I think the latter. So I think it's, costing is useful, but I think the most useful thing about costing is this process that our colleague mentioned. So thank you.
Thanks, everyone. I think that was great. Dr. Malukan, do you want to respond to anything, or can I go through the questions in the chat box? I think Dr. Malukan's frozen. Okay, I'm going to go through some of these questions. So Sarah, Kate, I think you've touched on this already, but I don't know if there's anything you want to expand on from Sam, asking about the contingency of funding that's been made available through grants versus loans. Sam is from UNICEF and is calling for more of the funding to be provided on concessional terms. So if there's anything you want to respond there. And then Natalie from the WHO has also asked a question to the speakers in general about whether the COVID-19 vaccination costing work done by immunization programs has been used by the Ministry of Finance for grant negotiations. So this will be to Dr. Malukan, but I think we've lost Dr. Malukan now. And Natalie was also wondering whether the COVID-19 vaccination budgets will be in the hands of the Ministry of Health and integrated into the Ministry of Health budget in 2022. But I think, Dr. Malukan, I think we have lost you. Yeah, unfortunately. Okay, Sarah Kate, do you want to expand on the question that Sam asked, or have you covered it as much as you want to?
Sure, and we just mentioned it in the chat, but so whether or not it's a grant or loan depends on the country's status in terms of income, creditworthiness, and other factors. So most of the poorest countries, largely that's grant financing. So it's in line with our lending, our eligibility criteria, and where countries fall. So there are more details on which of those. I mean, you can also look to see the lending terms for each country, but even the loans are highly concessional. So hopefully that answers your question. I think roughly 1/3 of the financing approved to date has been grant. And of course, for the poorest countries, it would be, the majority would be grant. And so that also includes, I mean, this financing envelope is a mix of, it's about half IDA and half IBRD. Hopefully that answers. Thanks.
Okay, thanks so much, Sarah. So I also had some questions for Dr. Malukan in terms of how financing has been incorporated into the actual budget and how these costing estimates have translated across. But maybe another country wants to speak to that and some of these questions that we've included in the discussion points. Otherwise, I might ask you some more questions, maybe while we wait for other countries to brave up and take the floor. But I was just wondering, in terms of, we've seen that there's only 2 billion that's already been allocated. And I mean, I understand these things obviously take time, but maybe you can go through some of the challenges that you faced in getting that money out. So how countries qualify and what countries need to be doing in order to qualify. And it would be great if we can hear from countries who have already applied for this financing, some of the challenges that they faced, and also how the process has gone. So just we can have a dialogue on that. So maybe, yeah, in terms of the qualifications that countries need to show to the World Bank in order to qualify.
Okay, so I think the number, when we look at the 20 billion and then we see, so it's 4.7 globally and then about 1.8 right now. We are seeing, so we saw it between April and July, we saw a doubling of approved projects. And then we have seen a bit of a plateau. Now there are countries that are preparing projects now, so those would not be reflected. But I would say, one of the challenges countries face is this uncertainty in the supply landscape, uncertainty with the donation, when countries are having to do so many things and finance so many needs, including essential services and pandemic preparedness and vaccines. Is it the case? And I would turn this question back to the countries, but when we're hearing, oh, there's donations coming, oh, we're not sure, should we use our precious resources, including this IDA and IBRD resources, should we use those to allocate to vaccines? It's really, there's a lot of confusion there. And so we've had to spend a lot of time having a dialogue, but the best thing we could do is have better transparency in the deliveries. And first of all, the manufacturing, and then that has been confusion for the countries. And then also the deliveries and knowing when, trusting that, if we allocate these resources, the vaccines will come soon. So I think there's a lot we can do. In terms of eligibility, it's really in line with our financing, and that requires a broader conversation, but it's different than applying for a grant. So it's a long-standing engagement that we have with countries, and they can choose how to allocate their IDA and IBRD resources. So this money has been earmarked specifically for vaccination programs within a broader envelope. So countries will choose, it's demand-based, and countries will choose whether or not to draw on that. So hopefully that answers your question. I don't know, Kate, if you want to add anything.
Thanks, Sarah. Just to add on Sarah and to respond to the first question on how these costing of vaccination has been included in the budget planning for the government, the answer is absolutely. The cost estimates has been used by countries. The World Bank has been preparing COVID and vaccine projects. One of the major exercises that we had to do was to prepare costing estimates of the vaccination rollout. And as you know, and as we briefly discussed, there are different costing tools at the country level that we can use. The first one that we mentioned and we have used today was the World Bank Resource Estimate Calculator. And this is more of a basic approach to assess approximate resource estimates, which is including the average cost, dose, and the service delivery supply chain that we discussed today, and the WHO civic tool. And I'm sure maybe there are people from the WHO who has more detailed information about this, but that is a more detailed approach that includes the phase approach for target groups, and they have very detailed information around the HR and I'll deliver parameters and vaccine supply and the delivery modalities. I hope that helps in terms of the first question. Over back to you.
Very much. Thanks so much, Kate. Thanks, Sarah. That was great. We have two hands up. I think the first one was Mr. Diop Samba from Senegal. I saw ARMP, and I'm assuming that's the procurement authority.
Thank you very much. I'd like to thank you for this presentation. And I would like to ask you that how that it is possible to support African countries in order to develop local vaccine in order to resolve this matter of COVID-19. I think that it is very good to support our country in order to finance the vaccine, but I think that the best thing is to support the laboratory in our country in order to develop local vaccine. That it is possible to support this kind of program. Thanks a lot. Thank you very much.
Thank you. And absolutely, it was really reassuring to see Danielle's slide. I love that slide with the progress made on manufacturing capacity in Africa. I know that the IFC has been working with Senegal on this to increase manufacturing supply. So thank you. I agree.
I think we all agree that in terms of resilience and self-sufficiency, that's where things are going to be key. Thank you, Mr. Simba. And just to note that this is available in both French and English. So if you click the interpretation button at the bottom, you can choose your language of choice, whatever's preferable. And you can also speak in whichever language is more comfortable for you. Mr. Abdoulaye Kaba, I think you also had your hand up, and I'm glad you managed to join us. If you can come in now from Guinea, thank you.
Et bonjour, et je suis.
Good afternoon. I'm very happy to receive information in these presentations. this presentation really gave me a lot of information. I would like to mention that for the lessons learned, Guinea has a strategy, a vaccination strategy that follow the mechanism for vaccination, for procurement, as well as they were presented here, because we always refer to WHO and World Bank. But the problem we had at the moment, because of the context in Guinea, which is a big special, because we had a military putsch, and we saw that the World Bank, which is one of our main donor, suspended the funds at the moment. So what should we do when we know that a great part of financing vaccination was negotiated with the World Bank? What could we do? What should we do in this exceptional situation in Guinea in order to release the World Bank funds related to the special situation? Now in countries like Guinea, there are priorities, like, for example, mother that die when giving birth, and there is also malaria that kills more people than COVID. But it's still a priority of the country to vaccinate population in order to have immunity, collective immunity by the end of the year. So lots of funds go to vaccination and are lacking now other intervention like mother giving birth and malaria, for example. Now, concerning the tests, producing tests locally, I think that the initiative of Senegal and other countries are very good, but I would like to say that if we go through the African Union or regional organization of West Africa like Senegal, I think it would help as well to have access to close country, to have access to tests as well as to have access to vaccines. Thank you.
Excellent. Thanks so much. I think that was a very important intervention. Sarah, are you up for responding to that?
I can't say that I am informed about the situation in Guinea, but I know was an $80 million project. And so, of course, that is substantial. I mean, I think the best thing in terms of this is where, aligning development assistance with, and really, I know we are working with Gavi closely to identify countries where we cannot, as the bank right now, support, to try to identify, whether, other resources could come in to supplement to some extent. But I don't have that information. I think I would like to follow up. And I'm sure you're having that dialogue with countries. I don't know, Caitlin, if you have additional information.
Thanks, Sarah. Just to add on Sarah, I understand that Guinea's health system, but it's not just Guinea, right? It's all around the world where Africa or globally, health systems have been struggling with COVID, where the prioritization has been more focused on COVID and vaccination rollout. So health system strengthening has been a back burner, right? So this is why health system strengthening and proper investment should be well designed, and have the government could benefit from focus on building infrastructure and having strategic partnership and ensuring that key enablers, such as the fundings or dedicated to health, are in place. And I also wanted to respond to Dr. I forgot the name, but in terms of the importance of development in Africa's COVID vaccine manufacturing landscape. And it is true that major reason for the low vaccination in Africa is lack of available supplies. And countries like Guinea or in Ethiopia and Africa in general the manufacturers believe it's around 1% of all vaccine administered in the continent. So absent local vaccination production and African countries mostly relying on COVAX or very small bilateral deals have faced severe supply shortages. So it is important to ensure that the Sub-Saharan Africa and the government is able to secure vaccines for COVID in the future, which will require sustained commitments from the government and also regional coordination by the African Union and also international community, and consistent financing and research and development that Sarah mentioned before. Over back to you.
Thanks so much, appreciate that. So I think we have Dr. Malukan back with us. So I'm going to quickly pose the questions to him that I wanted to ask earlier, because I really am interested to know in terms of how much of this costing is translating into national budget documents and the discussions between the Ministry of Health and Ministry of Finance in negotiating the amounts that have been allocated. I've tried to do my research and couldn't find much in terms of that. So it would be interesting if Dr. Malukan can come back and respond.
Daniel, yeah, thank you. Sorry, I mean, I didn't hear you on the first question. Sorry, apologies. Yeah.
No problem at all. So I was just asking in terms of how the costing exercise translated into the budget and where in the Ministry of Health's budget this fits, and also just some of the discussions in terms of the negotiations between Ministry of Health and Ministry of Finance. So what did those discussions look like? How did you convince the Ministry of Finance that this is a worthwhile investment?
Yeah,
thank you.
Yeah, thank you. I think this is also a very, very important point. Thank you for raising Daniel. I think the ultimate issues, I mean, finally, there was a lot of negotiations between World Bank and actually the Ministry of Health. Because as you know, at the end of the day, when the budget was actually approved, then there is a procedural issue that it will go basically until it is actually approved. So based on that, we really deducted some of the costs, actually some of the overestimated costs, some of the costs which can be some of the activities which can be actually done simultaneously, and a number of issues basically. So even though at the beginning the total cost was like nearly 354 million USD, but ultimately we agreed for the final budget that was approved by a World Bank was 207 million USD. Of course, there were certain expectations from the World Bank, contribution by a government, but in any case, you can see basically a significant reduction from the original estimate. So this has given a lot of lessons for us. One, basically, we need to refine basically, our costing exercise. Basically, the very important assumptions that we were actually considering at the beginning were actually, changed through time. By the time when the budget was actually approved, even the price, the vaccine costs, and everything was actually changing. So finally, the 207 million USD was approved. But the bigger issue is actually, as far as I'm concerned, is how are we basically, our pace basically utilizing these finances. So I would say it's very, very, very good. Because the initial assumption when the team was doing that costing exercise was actually, they had the mentality of, the measles campaign where they will vaccinate basically, the whole 20% of population within a matter of basically, 45 days, given that, the vaccine availability. So that was not actually the reality. Because of that, our pace basically to utilize the budget is very low, even though there are additional requests from the World Bank basically for us, additional opportunities, but still actually they were considering, budget utilization rate that was already approved. So because of that, we are trying our best to utilize those budgets, but at the same time, we are actually translating those budgets to the actual physical budget that we had the finance directorates. So the finance directorate is actually and the grant management units are closely following our budget utilization, and at the same time We have also, the program team actually requesting, the domestic contribution basically to be reflected on those issues. So we are trying our best, but given that, the vaccine hesitancy issue, some of the global vaccine shortage issues, some of, the compounded complex issues, then still actually we are struggling. But now we have brought this issue to the attention of the leadership, the ministry leadership, and beyond that, and definitely with the support of, the higher officials, we will definitely come out of these challenges. So this is in brief. Still, I'm more than happy basically to respond if there are any issues with Daniel. Over.
Thank you so much, Dr. Mulukan. I think we're going to need an entire session just on unpacking some of the stuff that's come out of today. I think there's a lot of useful peer learning and opportunities just on costing during a crisis and how these things do change and how to handle uncertainty. But we've almost come to the end of this session, so I'm going to just ask if there's anything that anyone else wants to add as a last contribution, and then we can wrap up, and then we've got a short comfort break. So thank you so much to our speakers, Kate, Sarah, you were excellent, and I'm again grateful. I'm not a morning person, so I think that's why I keep reiterating how grateful I am that you guys were both awake so early. And Dr. Mulukan, thank you so much. This was just excellent. Thank you. And to the other contributors as well. Thank you.
Thank you.
So this session on procurement and distribution and supply challenges is going to be facilitated by my colleague Shanaz Broman. And Shanaz leads the climate financing and budgeting work at climate change financing and budgeting work at CABRI. Thanks so much, Shanaz.
Great, thank you, Danielle. Good afternoon and welcome everyone to this session, which looks at some of the challenges of pooled procurement and distribution. And we've already had some really excellent sessions this morning, so I hope we can continue on that trend. So we will start with an update from UNICEF on the COVID-19 vaccination supply and distribution, and this will be followed by insights from South Africa on how they are addressing related procurement challenges. I'll then open the floor for questions and comments, and hopefully just have a more sharing atmosphere. So I'm really pleased now to introduce Samuel Kweku Okran and Bob Muchabaiwa from the UNICEF Eastern and Southern African Regional Office, who will give a joint presentation. UNICEF, you have the floor.
Okay, thank you very much, Shanaz, for the introduction. I'm Samuel Okran, the Regional Chief of Supply and Procurement, and I'll be, myself and Bob will be representing UNICEF on this event. I must say that it's a pleasure to be part of this discussion, and we're looking forward for more interactive engagement. Bob, you want to introduce yourself, or you wait when it gets to your turn before I go on?
So please go on, and good afternoon, everybody. Bob Muchabaiwa, Public Finance Specialist for UNICEF Regional Office. Thank you. Back to you, Sam.
Okay, thank you, Bob. So to start, I must say that, when I saw the time for the event, the presentation basically is about 20 minutes. I was just thinking, what do I focus on? Because the time is really very short to be able to address the issues. But I hope that during the interactions, we'll be able to address questions that are not in the presentation. So first of all, COVID-19 vaccination supply and distribution, update and implications for ministries of finance. This is a very interesting topic. Can we go to the next one, please? So I will start the presentation with just to give an overview of what is happening globally with respect to vaccine procurement and also delivery. So next slide to the next one, please. Okay. So if you remember when the pandemic broke out, there was an issue as to how do we deal with this. So we had Gavi, WHO, CEPI, UNICEF, and others came together to rally the international community to form the COVAX facility. And the main objective of the COVAX facility was to make sure there's access of vaccines to everyone, every country. So the principle for the COVAX is access equity to ensure that we can all collectively deal with the pandemic, because if one country handles it and the other does not, the pandemic will not go away. You remember this pandemic started in China and it's all over the world now. So we are all in this together. Now, through that initiative, COVAX has allocated over a little over 500,000 doses of vaccines to countries, basically 143 countries, out of which 300 and as of today, 330 million doses have been delivered. So we will look at what percentage of this has come to our continent and also why. So can we go to the next slide, please? Now, you will see from here, and courtesy WHO, on our continent, there has been 176 million doses of vaccines that has been received so far in 52 countries. Now, out of this quantity, 132 million doses have been administered. So this shows that we still have a number of vaccines on the continent not utilized. So we have over 40 million doses of vaccines still on our continent not being used. They've not, I mean, some have expired, but majority have not expired. So this shows that the issue we have now is not vaccine availability, but it's about vaccine administration. How do we ensure the vaccines that we have in our hands are fully utilized? And also utilized within the priority group. If you recall, the priority group, most countries have abandoned it because they are not getting enough, generating enough demand from there. And as a result of that, they've widened the group to be able to make sure vaccines do not expire. And once we continue to do that, then the pandemic is going to stay with us for long, or we're going to have more mortality, which we don't want to happen. Now, of all the vaccines that we have, I mean, while other countries have achieved over 60% and others, we are still under 3% doses administered in Africa. Can we go to the next slide, please? Okay, so here, this shows the quantity of vaccine that has been allocated to countries on our continent, and also the percentage of doses that have been received. Now, you see that a number of our countries are under 50%. Significant number of them, it's more than half. Now, why is this the case? There are so many reasons that are attributed to this. One is that one of the challenges we're having is, before we started the pandemic, we started delivery of the COVAX. We made government or countries to be aware that there are conditions for receiving vaccines. And these conditions were not put down by COVAX, but some are from manufacturers and others also to facilitate the delivery of vaccines. So for example, we have the pre-delivery conditions that requires that government, first of all, waive import license to make it easy to bring the vaccines in. And then also we have the national regulatory approval. All governments, approve this. They agree to that. However, when the vaccine is ready and you want to bring it into the country, they still ask you for documentation, which therefore defeat the whole purpose of making sure that we remove all bottlenecks to allow vaccines to come in. Now, just to give you an example, we have countries when we have, say, a vaccine, AstraZeneca, which is produced in multiple countries. They want to approve every individual location of where the plant is situated, which is a big challenge because the first dose you deliver, if it's coming from, let's say, Spain, and the second one is coming from Netherlands or UK, you need a separate approval for this, which is an administrative bottleneck, and that delays delivery. And also, depending on how much time they take, it also affects the shelf life of the product, because the product is already produced, and then you are working with government to approve this site to enable you to bring in vaccines from there, which is a big challenge. Now, the other challenge also, why also these are a significant number have received small doses of the vaccines allocated, is also because they do not have the capacity to administer. We have countries that are even less than 15%. They've received less than 50% of the allocated doses, and still they cannot use them. So it becomes difficult to send additional doses there. You have to wait till they use what they have so that you don't waste vaccines through expiry. The other issue we have, and you recall that the US government gave significant amount of Pfizer vaccines. And these Pfizer vaccines were not anticipated to come to our continent originally. When we reviewed the national vaccination deployment plans, there were only 2 countries. For example, if you take Eastern and Southern Africa, it was only Angola and Rwanda that had the facilities in terms of ultra-cold chain to receive Pfizer vaccine. And those were even small quantity of vaccines. Now, when the US doses came in, because we had challenges with SII, the Serum Institute of India, to produce the AstraZeneca, what we've seen is that there has been a lot of effort by the international community and COVAX, especially from Gavi, to improve the cold chain facilities of countries. Most of this cold chain takes time to come, and as a result, you cannot send the vaccines in, though they've been also allocated. And also the complication that comes with the Pfizer vaccine in terms of the logistics. You need ultra-cold chain, you need diluent, you need special syringes. The routine syringes for routine immunization is 0.5 ml. The one for Pfizer, there are 2 syringes. One, you have the 0.3 ml, and then you have also the one for diluent, which is the 0.2. Now, without this, you cannot administer the vaccine. So these also bring complications. And then the cold chain requirement of all this makes it even much more complex. And then the other thing, which is also making it impossible to also deliver as much as we can, is also the fact that right now as we speak, government or countries are asking us that, because of the slow uptake, please, though the vaccine is allocated, please keep it. We will let you know when we are ready to receive. So the message now, you see it later, is not necessarily more vaccines, but the vaccines that are available, let's show we have the capacity to use them. And the reason the government are not probably administer as much as they can is because they don't have the funds to cover administrative expenses that are associated with the logistics and the actual moving of the vaccine from the boxes onto the hand of the individual. Can we go to the next slide, please? Okay, so now this shows the African Union vaccine. I mean, we've heard a lot of comment about the fact that COVAX is slow, COVAX is not delivering. If we had known, we could have probably organized ourselves by some government. Now, African Union offer a facility for governments or countries to buy vaccines. Now, these are the quantities. You see the quantity on cost estimate is the quantity governments have committed to buy. Apart from Nigeria, that has bought over 1 million, all the countries, the majority, about 90% of the countries are buying less than 200,000 doses. So it means there's a challenge. Now, what it means is without COVAX, probably there will be very little vaccine on our continent. And I think we need to acknowledge that as well. So the issue is not necessarily vaccine availability, which is preventing vaccination on our continent. Because if it is, we have opportunity to buy vaccines through J&J, and still we are not buying. So there are more reasons why we are not vaccinating. And I think that money or funds play a significant role. I'm sure if government have the funds, they will buy J&J, because J&J, you require very little logistics to manage it, especially for hard to reach locations. You just give one dose and you're done, at least for a period of time. Next, please. Okay, so this again shows, for the last few weeks, especially from mid-August, you could see that the doses that have been received are high, and also vaccine administration is also going up, but there's still a gap. For example, the last week, we received 12 million, just within 12 million doses of vaccines were administered against 15 million doses that were received. This does not take into account what was already there. So for the last week alone, there has been a gap between what is received and what is administered, and you can still see the gap. It's still very significant. So what we need to do is to make sure we improve not just the procurement, but uptake of vaccines. Now we'll go to the next slide, where we have the key messages. Okay, so the key messages here is we need to basically support countries struggling to achieve high coverage in priority areas, like the elderly, especially the elderly, and other people with severe health conditions. And as I said, though, in the National Deployment Vaccination Plans, we had put this as a priority, almost every government, because that was one of the recommendations from the WHO, notwithstanding that we've not been following this rigidly. And this is also one of the reasons. In fact, if you look at the statistics, it tells us that most of the people who are dying are coming from this priority group, these people who have not been vaccinated. And Kenya is one of the countries that have shifted their strategy to cover, not just the priority, because they're struggling to reach these people. Now, we also need to adopt different strategy, because on our continent now, we have 6 vaccines on our continent, so we need to manage how we administer these vaccines. And because of the cold chain complications with Pfizer, it may be good to concentrate Pfizer vaccinations within the cities where the ultra cold chain may be available, and then use AstraZeneca in rural communities where cold chain may be weaker, because of the fact that AstraZeneca is much more easy to handle, 2 to 8 degrees. And then also for hard to reach locations, to use the J&J, because it's 1 dose and you are done. Now, so in a nutshell, what we need to do is more or less to have an effective strategy to increase vaccination on the continent, and not simply more vaccines. We need to use what we already have to show we have the capacity to absorb more, so that what is there can also come in. I will invite Bob to handle the rest of the presentation. Bob, over to you.
Yes, thank you so much, Sam and colleagues, Daniela and Kabri, for organizing this very important event. In this second part, I'm going to focus on the financing elements. And this is premised on 4 main observations. And I'm happy that the colleagues that spoke earlier on, Sam and colleagues from the World Bank, already highlighted these 4 observations. Number 1 is, roughly, we have an idea of what is required, right? We have rough estimates of how much we need to deliver vaccines to about 70% of the population. Number 2, we've also observed that, yes, many countries benefited from pooled procurement, but increasingly there's a trend towards bilateral procurements. So this is a reality that we see in quite a number of countries in our region. And then the third observation, and this came out very strongly from our colleagues from the bank, is that the fiscal burden and the responses vary considerably across countries. If we look at the per capita estimates to deliver vaccines, and you compare that with the outspending, it really varies very considerably. In some countries taking almost half of the per capita spending on health in total. So this basically should tell us something. And then, of course, lastly, we have observed that the level of efficiency in procurement and distribution and in uptake of vaccines varies also considerably across countries. Now, there are several reasons for that, and I don't want to belabor points that have been raised earlier on by my colleagues, but I just want to highlight a few key messages to ministries of finance. But before I do that, I would like just to acknowledge the different local and international actors that have been contributing to this. If you look at this slide, and I must say the international community is doing all it can to ensure that resources are available to deliver vaccines to the continent. So colleagues from the bank have already talked about the 20 billion window. We also know that the African Development Bank, the Islamic Development Bank, there's a lot that is happening. Bilateral donors, UNICEF, Gavi, lots of commitments have been met. But I want to highlight one main challenge, which Sam has alluded to in the next slide. And this challenge is that if we look at this particular slide, most governments are actually planning for doses, but there is a gap in terms of vaccine delivery financing. And what you see on the slide there is we do estimate a funding gap of about $2 billion. I mean, this is just for the 44 African countries, and we can provide a list if required. Now, what this means is it is not enough to simply have doses. We need to effectively plan for the delivery if we are to improve the efficiency of vaccination. So we look here, this is what we need is plus or minus almost nearly just under 2.5 billion. And what is confirmed at the moment is really far below 500 million. So what this means, and this brings me to the main messages in the next slide. Now, from this slide, we can take our first key message. And the first key message to ministries of finance is that we need to comprehensively cost COVID-19 vaccination programs. And we've already talked about the doses, but we need to include delivery costs, such as transport, cold chain, waste management, human resource surge costs, per diem monitoring. And many times this is the missing link. And we would want to encourage ministries of finance to pay particular attention to this element. Then the second key message really is, yes, the international community is doing all it can, but ultimately governments have to increasingly do something. And the starting point is to ensure that the cost estimates for both vaccines and delivery costs are reflected in annual budgets and medium-term budgeting frameworks. And I want to also say, while preserving financing for essential health and other social services. We do not want COVID-19 to crowd out immunization, antenatal care, and many other essential health services. So we should keep the system running while increasing spending for vaccination. And so this is the second important point. More so because a lot of countries are actually procuring bilaterally, as I have highlighted earlier on. Now, the third key message, and this arises from the third point I alluded to earlier on, that the fiscal burden, and the colleagues from the World Bank made this point very clearly, varies considerably across countries. We know that many of our poorest countries will not be able to do it alone, will require support. So we are encouraging ministries of finance to explore non-debt creating external financing flows. This could be grants, concessional finance, right? To ensure that we cover the vaccine delivery cost in addition to the doses. The idea is we don't want to increase indebtedness. And I know my colleague Sam raised this particular question earlier on, and our counterparts from the bank have already responded and said, look, for most poorest countries, quite a good share, up to almost a third or even more, are grants, which is very much commendable. We are also challenging ourselves to think outside the box and say, look, for some countries, is it not time to talk about COVID-19 vaccination debt swaps? Yeah, right? And meaning ministers of finance can talk to some of their creditors and say, we can commit the resources we would have put to debt service to procuring vaccines, because we know that the funding gap remains significant and we need to cover that gap as much as possible. Then, of course, we keep encouraging ministers of finance, and I'm glad many of them are represented here, to enhance efficiency and transparency in vaccine procurement and delivery, especially as we move away from pooled procurement to more bilateral or direct procurement. This is important to ensure value for money, but also to inspire confidence in the citizens, the taxpayers, and even other financiers. And this, I want to link it to the last point on oversight and accountability. It's also important to ensure that we strengthen oversight, we strengthen accountability for every cent we receive. I just like the statement by our colleagues from the International Monetary Fund when they say we must keep receipts, and ensuring that there is transparency and accountability. And I must say the stories we're hearing from many African countries are quite encouraging. Some of them have put in place web portals to publish this information. That is commendable, and we encourage our countries to keep on doing that. Now, as I conclude, I want to just present the UNICEF offer. We're not just here to just talk and talk, but we are able to support ministers of finance and governments in the following ways. We can provide technical and financial assistance in the costing and integration of cost estimates in budgeting and medium-term frameworks, especially the neglected issues, the vaccine delivery cost I have alluded to earlier on. So we are available and we are offering ourselves. Should you require support, please do not hesitate to contact us. We are also offering technical and financial support, again, in conducting diagnostics, tracking flows, vaccine delivery, efficiency in the chain, and so on and so on. So we are happy to work with governments in that space. Again, we are quite actively involved in the planning and procurement of vaccines. I know, we have worked with many governments in Africa, basically to procure several health commodities and now COVID vaccines. So we are on standby, and as an active member of the COVAX facility, we continue to pledge our support to ministers of finance and government. And then, of course, we remain available to provide technical assistance in other services, right? Immunization, primary healthcare, actual vaccine delivery, including of COVID, the planning, delivery, and management of vaccine campaigns, as well as social mobilization. So what we are saying here is, colleagues, we have seen a hybrid kind of model where countries are mixing both pooling and direct procurement. That requires the proper financing, proper budgeting, ensuring that we reflect all the costs that are required and ultimately improve efficiency in the delivery. And the end game is the same. We need to ensure as many people as possible are vaccinated as soon as possible. And I want to stop here and hand over the mic back to the moderator. Shanas.
Thank you so very much. Thank you, Mr. Okran and Mr. Machabaiwa, for that very stimulating presentation. I think what is evident from the presentation, but also some of the discussions that have taken place over the course of the afternoon, is that it's not as simple as complementing pooled procurement with some other sort. It's also about vaccine uptake. And some of those issues around poor vaccine uptake, which have to do with the lack of financing for vaccine delivery, including transportation, sufficient investment in the cold chain and in the human resources needed to ensure that vaccines are delivered where they need to be. And I think, what's also important to note is that these issues are not new. A lot of African countries have been grappling, with a lot of these issues for a very long time. But, what's important, particularly in the context of COVID-19, is that African countries will have to find a way to close the gap, not only to save lives, but also to ensure that Africa is not left out as the world, progresses to a new normal. So thank you so much for sharing those very important insights. I'm now going to introduce Khadija Jamolidin. She from the National Department of Health in South Africa. As well as Mark Blecker from the National Treasury of South Africa, who will share more insights into what South Africa is doing to address the COVID-19 vaccine procurement challenges. Khadija and Mark, the floor is yours.
Thank you, Shanaz, and thank you to our two presenters who preceded us. Just checking if you can give me a thumbs up if you can hear me properly, Shanaz.
Yes, we can hear you and see you very clearly.
Okay, great. All right, thank you. So we were asked to talk about a number of questions that were sent to us previously, which relates to the presentation we had just seen. And for us, the procurement mechanism related to the pool procurement, it was originally intended to cover 10% of the population, and that commitment was entered into with the COVAX facility, which I'm sure many other countries had also committed to participating in that facility. And this commitment was made with the understanding that vaccine supply was constrained. And we didn't want to have a situation where some countries take all the vaccines and other countries are left with nothing. So in the spirit of social solidarity, we entered into that agreement to ensure that we do receive some vaccine at least, even if it is to cover our high-risk populations, such as our frontline healthcare workers and the elderly. The procurement of the bilateral agreements are intended to cover or to provide vaccination coverage for the rest of the eligible adult population. So the vaccines being newly tested, we knew that based on the data available, they've only been tested in adults. They had at that time only been tested in adults. And so that was the target population that we had identified. And our target was to immunize at least 70% of our target population. So just following on what Shanaz had said, we see the pool procurement through COVAX as a supplement to procurement through our bilateral agreements and not the other way around. And if you think about the number of doses which we as South Africa have received currently, so we've received over 33 million doses. Through the COVAX facility allocation, the doses that we had purchased was just about 1.4 million doses based on the allocations. So if you want to plan a large-scale implementation plan with an ambitious target of vaccinating 70% of your population, the reliance on the pool procurement mechanism as it stands in the current COVAX agreement would not have met our needs. So in terms of the challenges or concerns that we had with the pool procurement mechanisms, there were a number of issues. The first relating to the uncertainty associated with the allocations, because you didn't know what volume would be allocated, which vaccine would be allocated, the timing and delivery of these vaccines. So the level of uncertainty that's associated with waiting for an allocation makes planning for a full-scale rollout very difficult. And as has been mentioned before by other participants in this meeting, if you have different vaccines as part of your campaign, each one has a different requirement, and there are risks associated with having multiple vaccine types as part of the implementation plan. And just to highlight some of the risks that are associated with that. So, with Pfizer vaccine, you need capacity, for example, to store vaccines in accordance with their cold chain requirements, and thereby diluting the country's ability to store vaccines as needed appropriately and effectively. There are logistical challenges which may arise, and I'm just going to talk about the Pfizer now, having the ultra cold chain, because you need specific equipment. There's PPE that you need to make sure that it is handled effectively. We don't want people's fingers falling off. And as it has been mentioned as well, you need to train the vaccinators to administer the various vaccines. So with Pfizer, they need to know how to dilute it properly, the needles that are different, etc., the storage requirements. And if you have too many different vaccines, people tend to get confused, and therefore the training is needed to make sure, training needs to be intensified to make sure that we don't have medication errors and increased claims against the no-fault compensation schemes. Another issue related to the pool procurement is the pricing of vaccines, and I think it has been mentioned, and I think Danielle did mention previously about the transparency around the medicine pricing. But also what we've experienced is the prices that we were able to get in terms of our bilateral agreements were different to the prices in terms of the pool procurement. And the expectation was that the pool procurement mechanism, because of the economies of scale, would likely yield a better price, and that is not has been our experience. The other thing that we also had an issue with was the Incoterms of the manufacturers. So, for example, Pfizer vaccine in the bilateral agreement had a different Incoterm to Pfizer vaccine in terms of the COVAX allocation, which made the procurement of the vaccines a little bit different, because when you do the financing planning for this, you need to keep in mind that the Incoterms will have an impact on the price of the vaccine itself. So just in terms of the challenges that we experience in terms of procurement and distribution, I think the biggest issue was the consistency of supply. I think everybody knows what happened with J&J and the Baltimore plant and the quality issues that arose. That had impacted on the scale and when we start implementing our vaccine program. So initially, due to the lack of the manufacturers to commit to the supply of the agreed volumes, and the short supply horizon. So you don't know when you're going to get it, and when you do have a supply horizon, we wanted 3-month supply horizon so that we can do proper planning, and they only gave us 1 month supply, so that was like 4 weeks supply horizon, and you had to plan based on that. So for a 2-dose vaccine such as Pfizer, it makes it very difficult, because now you've got to think, when will I have enough for my second doses? What this has resulted in is the need to constrain and allocate doses for in-country supply to ensure the steady pipeline to vaccination sites. So you didn't want some sites running out. The uncertainty of future supplies also results in a tendency for some entities to hoard stock. And we're seeing that now, because initially, when supply was constrained, there were some facilities in some provinces who actually lobbied for extra stock. And what they did was they hoarded that stock. And what we are finding now is that because they couldn't vaccinate the number of people that they thought they would, that stock is now at risk of being expired and having to be written off. But all of these challenges makes it difficult to plan and has the potential to drive incorrect ordering behaviors, which may result in wastage due to expiry, as I've already mentioned. Where the central warehouses have limited capacity, the lack of supply visibility could result in over-investment in expensive capital equipment or the risk of exceeding available capacity. And this is exacerbated by fluctuations in demand, which is difficult to forecast. So initially, when we opened up, according to the priority groups, there was the vaccine eager population, which drove up the demand in a short time, but then that demand kind of tapered off. But without sufficient data, forecasting has been difficult. And after 3 or 4 months of weekly vaccinations, this has improved to provide a view of demand to plan accordingly. So you need systems in place to make sure that you have the kind of information you need to plan for the demand. But there is a looming challenge, and everybody talks about the fact that Pfizer vaccines, ultra cold chain capacity makes it very difficult to handle. For me, what we are experiencing now is the short shelf life of the Pfizer vaccine. So with J&J, not only does it have a better cold chain storage requirement, but it also has a longer shelf life. So we are able to, even if we buy it now, we can keep it for a year or so. With the Pfizer vaccine, the shelf life is currently 6 months if you store it at -70. We know that there's data available to extend the shelf life by 3 months, and we're waiting for SAPRA to approve that, SAPRA being our regulator, to approve that. But this risk the risk of expiry due to this low demand, the vaccine hesitancy and the short shelf life does raise the risk of us having to discard some vaccines due to expiry. What are we doing to address this? There are doses that are in the system that are being redistributed between sites. So because we have visibility of what vaccines are sitting where, we are able to move vaccines from one site to another. And we've asked the manufacturer to defer some of the future vaccine delivery. So for example, we won't be receiving any Pfizer vaccine in October, but in November and December, we've given them a schedule when we would when we would like to receive the vaccine. And then just in terms of demand generation, there's a plan in place. And this weekend, there's a national campaign that will focus on outreach. And there's a lot of effort being put into making sure that we reach those hard to reach places. What we've also done in terms of the J&J, as has been said previously, we've kind of reserved the J&J vaccine for the outreach, hard to reach places, people who are unlikely to come back for a second dose, and the rural areas, and then having the Pfizer vaccine for areas where they are able to maintain the cold chain, and also where we are more likely to get people coming back for a second dose. Thank you, Danielle and Shanaz, over to you.
Okay, thanks. Perhaps I can come in now. It's Mark. Good afternoon to everybody. I'll try and be fairly quick. I've got about 7 or 8 points to complement what Khadija, who runs our medicine programs, has already mentioned. So firstly, if I look at our World in Data site on the vaccine coverage in Africa yesterday, the latest data they publish is dose to population ratio is 11%. The proportion of people vaccinated is 7%, and fully vaccinated is 4.4%. So that's yesterday. If we compare that to what proportion of people have already been infected by COVID in the continent. So in South Africa, the community surveys suggested that in the first wave, the seroprevalence rates were around 20%. By the second wave, the seroprevalence rates were about 45%. We don't yet have the studies from the third wave, but our seroprevalence is probably already 60, 70%. So most people in the country have already been infected by COVID. And this is, I mean, we've seen some studies from Kenya and some other countries, particularly urban areas. So the seroprevalence infection rates are way higher than what we're seeing in reported cases. So if we're at 4.4% fully vaccinated in the continent and 50% of people infected, in South Africa maybe at 60 or 70%, we're just way, way behind on vaccination. So really we, collectively have largely failed on this. And if you look at deaths, I mean, South Africa, has got about 60,000 reported deaths, about 200,000 excess deaths. Globally, it's reported there's about 4 million deaths from COVID, but that's probably only 10% of, with excess deaths, probably 40 million deaths. So we've already been through 3 waves with heavy deaths. And I must say that in that, COVAX as a supply mechanism has been really largely completely unreliable. I mean, we've been through massive waves of deaths. And I mean, of the 9 million doses from COVAX shown in the UNICEF presentation, 7 million of those are donations through PEPFAR and the US government. They're not actually doses that were ordered in South Africa. So South Africa's ordered 70 million doses, and we've only received, we've already had 200,000 deaths, and we've only received 1.75 million doses through the pooled mechanism. So the pooled mechanism has really largely failed us to date. And the question is why? And I don't think it's the fault of COVAX. I mean, I think COVAX is doing the best it can, and Gavi and UNICEF are doing the best they can. but one has to look at the bigger political and other forces that are driving the inability of the global organizations to do what they needed to do in this issue. And there are obviously a lot of dynamics behind that. So I do think that COVAX has largely not been very successful to date, but I mean, I think that one has to look at the reasons for it. Okay, fifthly, we struggled a lot with the initial contractual arrangements, and I think that's still a problem. That with the secrecy in the contracts, the nature of the clauses in the contracts. Even today, most countries are not able to disclose the contracts that they've had to sign. It's created a lot of difficulty with contracts, and I don't think the global organizations have also helped enough in trying to get more even ground for contracting between big pharma and countries in this whole process. I mean, contract negotiations was extremely difficult. Sixthly, I mean, I think, as Khadija pointed out, we've had a lot of problems with supply. The main problem has been actually getting the doses as opposed to the funding. I mean, that's been a much bigger problem, getting the doses. As it happened with one main supplier, the contracting was very difficult, but once we entered into the contract, the supply from that particular supplier has been very good. A second supplier, the contracting was relatively easier, but the supply has been really bad with that particular supplier. So even to date, if you look at the current COVID vaccines that we have, these are vaccines or medicines that are not normally registered yet. They are not supplied in the normal way. I mean, you can't get them at the local pharmacy. The contracts are only with governments. They're not in terms of normal agreements. So the whole process of supply of these commodities is not yet normalized. And I think that global organizations also need to pay more attention to that. So I think South Africa has ended up having to rely largely on the bilateral agreements it could set up. There's still a lot of ground to be covered. And I mean, I think I've also learned quite a bit from what the previous speakers have said. I mean, clearly all the organizations, are doing a lot of good work, but it's clear we are really still way behind with this pandemic. Thank you very much.
Thank you so much, Mr. Blecker and Mrs. Jamaluddin, for those very important insights. And I think, as you've shared, I think this is so important to discuss how the pooled procurement, as you've said, has largely not met the needs for South Africa. I mean, you've raised important issues around how allocations are made, both in terms of quantity and vaccine type, in terms of pricing, in a way challenging conventional thinking that pooled procurement should be cheaper. You talked about consistency of supply, but also about reliability. So thank you so much. And I just wanted to see right now if perhaps Mr. Okren or Mr. Machabaiwa would love to respond before I open up for questions from the floor. So you can raise your hand or write your questions in the chat. But yeah, for right now, I'll just see if UNICEF wants to respond to those very important comments made by South Africa.
Yeah, okay, Shanaz, thank you very much. And also thanks to colleagues from South Africa for the very country-specific challenges. And I must say that, I mean, those challenges were things that COVAX facility had initially perceived or anticipated. If you recall, the reason for the pool funding were some of the things, not just in terms of price, but also the general terms and conditions that govern the acquisition of the vaccines and also how vaccines are procured. Just to give an example, for example, we have AMC countries, the advanced market commitment countries, and then we have the self-financing countries. And then even within the self-financing countries, we have self-financing countries that agreed to be participant of COVAX facility, and but some agreed to be part of it fully and some partially. Now, South Africa is one of the countries that decided in essence to be self-financing, but self-financing participant, but self-procuring. So we need to put the discussion in perspective. Now, if you are self-financing participant, but self-procuring, the interpretation is that you want to be part of COVAX, but you buy it on your own. So which means that you have to do your own negotiations and others with the manufacturer that COVAX, WHO has approved, for which COVAX may have a contract. Now, what it then means is we cannot share the contract with you because these are all part of the confidentiality clauses that COVAX facility signs with the manufacturer. Now, manufacturers don't want the contract because contracts are negotiated on personal basis, one-to-one basis between the different entities that have the agreement. Now, for example, like if we take the self-financed countries like Botswana, Namibia, they are self-financing, but they rely on COVAX to buy on their behalf. What that means is that they are full participants and they don't need to go through any problems with manufacturers in terms of negotiating different terms and conditions. Now, I'm fully aware of the South African situation. If you recall, the first vaccines that were allocated, the first Pfizer vaccine, we had South Africa were allocated doses, Rwanda and Angola. Now, South Africa, because the negotiation delayed, as Mark probably alluded to, they did not receive the vaccine in February. Rwanda received, as soon as we allocated, in the next week, Rwanda received their doses of Pfizer vaccine because everything had been negotiated. They had nothing to negotiate with Pfizer. The only thing they had to do was Pfizer checking the country readiness to make sure that they are ready to receive the vaccine in terms of verifying the cold chain, training of healthcare workers, etc., as our first speaker from South Africa mentioned. So we need to put this in perspective. Now, for the AMC countries and also self-financing countries that rely on COVAX, didn't have to go through some of this challenge because even the delivery, the logistics, everything was handled on their behalf. So all they had to do was to wait and receive the vaccine. Now, the only challenge that COVAX also faced, as mentioned by our South African participants, were that, for example, we had challenges with getting vaccines because, vaccines were not available. When it started, everybody was scrambling for vaccine. And as a result of that, we had some challenges with getting the doses. And because also on the continent, COVAX strategy was to rely on easy to handle vaccines, which was AstraZeneca. So the other vaccines like Moderna, Pfizer was not a priority for COVAX because COVAX didn't want to go into the complication with managing the ultra cold chain because most countries didn't have the capacity. The syringes are different. I don't understand. I still don't understand why Pfizer alone, their vaccine are so complicated. Everything is different. Like the 0.3 ml, you also have different syringes for the diluent, so all these complications influence COVAX decision to rely heavily on AstraZeneca vaccine. And unfortunately, we had a challenge from the Serum Institute of India because of the problem India faced, and there was a ban on export, which brought a lot of issues. Now, with regard to, so that was the main reason with COVAX inability to supply the vaccines, and there was a gap. However, I must say, and I say this with confidence with what is happening, I think it was a blessing we did not have those vaccines, to be honest, because if we have 45 million vaccines on our continent and we still cannot use, if those vaccines have come, I think the truth of the matter is majority of our government would have struggled to use them. So while I think it was a challenge, I think it also helped us to manage the administration of vaccines, and probably has given us an opportunity to rethink about how we increase our vaccination as we speak. I can mention as many as 6 countries in my region alone who are asking us to hold on vaccine delivery because they are scared it will expire. There are about 8 countries that are calling us to reallocate vaccines because they cannot use them. And we also know, for example, in DRC, look at the percentage of vaccine they have to return because they couldn't use them. So I think that some countries like South Africa is one of the exceptions where they have strong capacity and therefore they may need more vaccines. But majority of our government are really struggling to be able to administer the vaccine. And I still say with no reservation that I believe that our focus and emphasis should be on vaccine administration rather than calling for more vaccines. But then we need to get more sustained vaccines in a staggered manner to allow us to basically use the vaccines in a way that will not expire. If I show you the status, we have vaccines that risk expiring in September and November. There are a number of countries. In Eastern and Southern Africa alone, we have 21 countries. And there are over 15 countries with vaccine that will be expiring in September. That we are working with them to make sure they increase the absorption capacity to be able to avoid vaccine expiry and wastage. I will pause here and probably we'll take more questions and then we'll be able to address some of the question. Back to you, Shahnaz.
Thank you so much, Mr. Okran, for providing that additional context, which actually shows that it is much more complex with so many, various layers to this. And also, I think it highlights that countries are different, and the challenges that they face are different, and therefore we have to be responsive to that. And governments have to, I suppose, proactively make decisions that work for their populations. We do have a question from our Executive Secretary, Neil Cole. Neil, you have the floor.
Thank you, Shahnaz, and thank you to Mark and Khadija for those inputs, and also Samuel for, I think, raising some really important questions and issues. I'm particularly struck by, what sounds like a diminishing return argument, which is essentially that, if you are increasing one output without paying attention to the, or at least one input without paying attention to the other inputs, a point will come when you are going to lower production, right? And I think your point that you make is a very important one around, whether it is just about increasing the availability of vaccines, or whether we should be paying attention to some of the other issues, such as the distribution, whether we have those logistics in place for effective distribution. I would add another, and that is having more effective communication campaigns. Mark and Khadija will confirm this in relation to a lowering of the daily vaccinations in South Africa. And it looks as if we're starting to approach that point where fewer and fewer people are voluntarily going to receive the vaccinations. So I think in terms of the context for many African countries, we're going to need to find what are those other inputs so that we don't, reach this point of diminishing returns because we're just focusing on one input being more vaccines. And then, Shahnaz, if you allow me, I want to make a point on confidentiality and transparency. And I want to take us back to an event that was held in 2011 in Busan, South Korea, where the Busan outcome document was put together by both donors as well as countries that receive and are dependent on development assistance. And this was one of those high-level forums that built on the Paris Declaration of use of country systems, transparency, mutual accountability, etc. And because we were now trying to, and I was there as representing the South African government on the steering committee, and we were trying to get as many countries and different sectors to sign off on the document. And the private sector in particular had some difficulty with the transparency clause, where they were saying that certain of the contracts require confidentiality. And I mean, I had an idea of, I suppose, what the reasons why they were arguing that way. But I now see with big pharmaceutical companies and where there's this global demand for vaccines, why there was this insistence on the confidentiality clause. And I mean, I suppose, just on my immediate reaction, also when I heard Mark speaking about this in April, is that, looking at this pandemic, considering the low vaccination numbers in Africa, these statistics on excess deaths, that, it's really about, I think changing the game plan, and I think negotiating as governments a lot harder and more forcefully with pharmaceutical companies with regard to the confidentiality clauses, because it has contributed towards impacting negatively on procurement, and also impacting negatively on the joint procurement or the collective procurement that we are trying to achieve in Africa. Thank you, Shanaz, and I hope I didn't go on for too long.
No, thank you so much, Neil, for those important comments. And I just want to actually check right now if we have Mr. Abdoulaye Kaba from Guinea on the line, if he would like to share some insights with us from there. Mr. Kaba?
Oui, je suis là. Je suis là, madame, oui.
Bonjour. Yes, Mr. Kaba, I just wanted to...
Yes, I'm here.
We just wanted to know from you if you maybe wanted to share some insights from Guinea as to how you're addressing this issue regarding procurement and vaccine financing.
Oui, c'est vrai que à ce moment-là,
it is true that I am on leave in France already for 1 month, but I am very happy to participate to this meeting, and I gave the contact of the representative of the Minister of Health, but however, I'm here. So yes, we started with our strategy regarding vaccine very early, and we anticipated the resource mobilization at national level, and also at partners such as the World Bank and the ADB and so on. And yes, we also entered into the strategy of COVAX. So definitely all these strategies enabled us to tackle the problem. But the problem we have nowadays is the distribution and delivery. We were not enough prepared, and we had also to train our staff and to vaccine priority groups, and now we are vaccinated vaccinate the population in general, but we still have problems, logistics problems, which would enable us to vaccinate our population in general. And we would like to have 20% of the population vaccinated until December. But I believe that our human resources and logistics is not sufficient for the moment. And we are trying to get organized to see how to attain this objective. So we had also financing from the World Bank at $10 million. So we are definitely busy with tests and also a vaccination strategy. So we started and we are utilizing all these tools. And otherwise, with the coup that we had in our countries, Guinea nowadays doesn't receive the funds from our donors or banks. It is suspended for the moment. So what CABRI can do to help us to speak with the World Bank yes, there is a coup, that's one thing, but otherwise vaccination must go on. So I believe that a suspended payment is not something that is helpful. And if CABRI could help us in this matter, that would be helpful. This is all what I could say. And my colleagues are from the Health National Division. If they were here with us, they would give you more updated information, but it is already a month that I am in France on leave. I'm so sorry for that. I don't have fresh information. Thank you.
Thank you so much, Mr. Kaba, for joining us as well while on your leave. We do appreciate it. We have one question in the chat or comment from Diana Chikua, and she's raising the issue of vaccine hesitancy amongst different communities. Hello? Was that someone who wants to come in? Hello? Mr. Kaba?
Oui, oui.
Yes?
Vokuma Evariste du Burkina Faso.
Okay, Everest.
My name is Vukuma Evariste from Burkina Faso. I believe the line or the connection is not stable.
J'ai pas encore dit quelque chose parce que nous devions être deux représentants. Oui, ma connexion n'est pas stable depuis le début. Vous m'entendez? Vous m'entendez? Voilà. Donc, depuis le début...
We can hear you, but it's smashed. I didn't want to intervene as there was someone from COVID at the Ministry of Health. So I know that there should have been another person, and I hope that this person would intervene. So that's why I didn't intervene up now. But otherwise, what I can give you from Burkina Faso is information. So our campaign, COVID-19 campaign, of course, I'm so sorry, the line is cutting. Bear with us. So we started officially on June, but we received 400,000 doses from the Chinese government, and we launched our campaign with the Chinese doses. Otherwise, we also received through COVAX a number of doses. Let me check the quantity. 115,000 doses from COVAX. Can you hear me? Yes, we can hear you, sir. Yes.
Oui, vous m'entendez? Voilà. Donc, je disais qu'on a reçu...
Yes, so I was 115,000 doses received AstraZeneca vaccines from COVAX, of course, and we are busy administering these doses. It's not about quantity of vaccines. The problem is the motivation of the population. So it is really, people are really reluctant. And we started with health care staff, healthcare personnel. I believe the line is cutting again.
Mais quand la campagne a été lancée depuis 2000, c'est ça le problème. Et je crois qu'on est au tournant, mais je ne sais pas si j'ai bien été attendu.
We couldn't hear the problem. Please, can you repeat, sir?
La connexion n'est pas bonne. Oui, j'ai dit on a reçu.
So what I was saying, that we launched the vaccination in June with 400,000 doses received from China, and then COVAX 115,000 doses. But unfortunately, we couldn't use all these doses as there is a reluctancy from people at grassroots level. We started with healthcare workers, as I said, and the line is gone again. I'm so sorry. And with priority groups, but the population remains hesitant and is not motivated to, and it's only 1 or 2% of doses administered so far. And we want to have at least 20% of the population vaccinated. So this is what we could hear you very well, sir.
Okay, it seems we have some connection challenges, but thank you so much to Burkina Faso for sharing those insights. We do wish that the connection was better so we could have heard more about how you are or how you are implementing the COVID-19 vaccine there. But unfortunately, it seems like we've come to the end of the session. I will now quickly just give each of the speakers 1 minute to just give their concluding comments before we close the session. So if I can just call on the speakers for the session, Mr. Okran, Mr. Machabaiwa, Mrs. Jamaluddin, and Mr. Blecker, just quickly checking if you'd just like to give very quick 1 minute concluding comments each. We can start with Mr. Okran.
Yeah, thanks, Shanaz, and also thanks to colleagues for their comment. I think that this type of discussion is useful because it gives us the opportunity to hear from government and also other stakeholders on what is happening and how we can work together to be able to address some of the challenges associated with vaccine distribution, procurement and distribution, and most importantly, to get it from the boxes onto the hand of individuals. So it's good that we're having this engagement, and we look forward to further engagement in this area. I will just end by saying that COVAX has not been perfect. We all know there has been challenges, but I think we also need to recognize the contribution by the international community by having this facility available to address some of the challenges. And I want to say this again, I think from the Burkina Faso example alone tells you what they received just 500 and they cannot administer from bilateral and also from COVAX. It tells you what would have happened if the SSI had produced. We'll probably be counting our losses by now. So we need, why looking for more vaccines, I think we should also acknowledge that we need to administer more. Thank you. Back to you, Shanice.
Thank you, Mr. Okran. Mr. Machabaiwa, you have 1 minute.
Yeah, no, just again to reiterate the UNICEF offer. We are ready to work with governments to address both the supply and demand side constraints. We know there are challenges, but we are available and willing to support. And I must also say congratulations to Kabri. Again, we are ready to join forces, especially on the public financial management aspects. Thanks to you and looking forward. Goodbye.
Thank you so much. I'm just going to check with you, Mrs. Jamolidin, for your closing comments.
No, thank you very much, Shanaz. I think just to mention that this kind of peer learning engagement is very fruitful. We've gained a lot from these discussions. And also what I've come to realize that oftentimes we have similar challenges, but it's not articulated in a way where we can get solutions to those challenges. And this platform creates that kind of an opportunity. So thank you very much.
Thank you for those very supportive words. Finally, Mr. Blecker.
Thank you very much to Kabri for holding an interesting session. It was really interesting to hear from the different countries. And good luck to you with your programs and your vaccine rollout. I think for me, the discussion also highlights, as one, the vaccination program clearly is becoming a more long-term issue. The linkages of this program to the broader UHC agenda, the broader health financing agenda is going to become increasingly relevant, and several of the participants have already mentioned that. So thank you all very much.
Thank you. I'd just love to take this opportunity now to thank all the speakers for your frankness and openness and allowing us to have this important conversation today. So with that, I'll close the session and hand it back to you, Danielle.
Thanks so much, Naz. Thanks everyone in that session. It was so much interesting information. It was great. So we're going to skip our break. I'm sorry about that. We're going to launch straight into the final session, and that's going to be moderated by Dr. Philip Krause, head of the technical team at the Kabri Secretariat. Over to you, Philip.
Thank you very much, Danielle, and thanks everyone for joining us today, especially for the stamina of doing this through odd time zones and everything else. I've certainly been busy taking notes, and that's true even though I actually know most of what was being presented here from the prep work. Let me launch straight into the final session now. This is going to be about reprioritizing budgets towards COVID vaccination programs. It is, in a sense, where many of us know the rubber really hits the road. If it's not in the budget, then how is it ever possibly going to happen? If it's not, and we all know these nice quotes that are being passed down from us through the ages, from Goldshire, Schumpeter, all these gentlemen from Austria from 100 years ago. The budget is the skeleton of what a government really wants to do, and whilst that is sometimes a way of sounding a bit clever, it is of course really true when it comes to reprioritization, especially reprioritization on short notice, under pressure, where expenditure needs are suddenly changing because of external shocks like the one that we've been discussing here. And so I'm very pleased that we are joined today by Claire Poitevin, who did some research on this and has done a really interesting paper. So the session is going to kick off with a presentation from her. We had been hoping that Ben Akaboise, the Director General Budget from Nigeria, was then going to offer some discussion comments. Unfortunately, he has been detained by his political masters and is not able to join the session in person. And I guess any of us here who have ever worked as civil servants would understand that they are just more important things than even joining a CABRI meeting every now and then when you have an actual country to run. I'm therefore very pleased that Aika Nayo from the Budget Office of Nigeria has agreed to step in on very short notice. And finally, we are also joined by Andrew Blasey from the OECD, who is also going to offer some observations from the perspective of the OECD, which hopefully is going to offer both interesting contrasts as well as some similarities, and to maybe give a little bit more of an opportunity to listen in to what other people are saying. I would suggest that we flip the sequence around slightly. Claire, why don't you take us off? Then it would be Andrew, if you could come in first, and then it would be Ike taking up the rear. And hopefully if we have time left, there should be a good amount of time left at the end of these contributions for some Q&A afterwards. So without further ado, Claire, the floor is yours.
Thank you, Philip. Good afternoon, everyone. I hope you can hear me okay. Many thanks for this opportunity to talk today. So my name is Claire Poudevin, and I'll be talking about the topic of budget relocations. First, about how it was used during the year of 2020 to respond to the needs brought by the pandemic. And in the second part, we'll look at a few cases of countries allocating and reallocating domestic resources to fund the procurement and distribution of vaccines. Next slide, please. Thank you. So before getting to the vaccine, I'll briefly summarize the use of, as I mentioned, budget reprioritization in 2020, based on the paper that was prepared for CABRI. And I'll start by giving a very brief overview of the main types of tools of budget reallocation available. I won't go too much into details, as I'm assuming everyone here is familiar with this concept. But still, here's a summary of what happened last year when COVID hit. So states had, of course, to react very quickly, and given the context of fiscal constraints, reallocating existing budget allocations was an absolute need. And basically, countries had the three following types of mechanisms available. First, in-years adjustments. All countries have, through different modalities, the possibility to move around through environments, through transfers, through décret d'avance in Francophone countries, which allow the mechanism which allow the opening of emergency credits and increasing the allocations previously decided in the initial budget. And those provide a very good short-term response mechanisms, but they also come with limits, usually in the form of ceilings, and ceilings under a certain program or a certain appropriation category. And they're here to hold the governments accountable to the budget that they adopted in front of the legislative body. Another option available were the contingency funds. Most PFM legal system do include the possibility to access, under a specific set of circumstances, usually some form of emergency funding. So last year, for example, it was used by Tanzania, Lesotho, Uganda, just to name a few. And the big advantage of those funds is that they ensure rapid access to liquidity in the case of unforeseen events, typically like a pandemic. And the thing is that not all governments decide to include a contingency allocation in their budget. And in any case, for governments who did have access to a contingency fund, those were never sufficient, given the size of the expenditure needed to fund the COVID response. And so finally, countries have the legal option of going back to the parliament to deal with unexpected events, or in the case of a significant change in fiscal situation. And those were used, those supplementary budgets were used in a very large scale in 2020. They serve the double purpose first of well, they give you the option to revise the revenue and expenditure estimates, but also they allow to register in front of the Parliament expenses that were done in excess, even prior to the presentation of a supplementary budget to the Parliament. So most PFM systems will also have restrictions in place regarding the use of this revised budget. That could be either the number of supplementary budget laws that can be adopted in a year. That's the case in Sierra Leone, for example, and also limitation regarding the circumstances in which this can be used. Usually they're referred to as unforeseen or unavoidable expenditure. And so what it means is that they need to be justified to the Parliament. Next slide, please. So this is just to give a little overview of how SBL's supplementary budget laws were used in 2020. So we can see that a large majority of countries did resort to adopting one. In the case of the 13 countries that did not adopt an SBL, it's interesting to note that a lot of those have fiscal year that differ from the calendar January to December year, which means that probably they would adopt their budget, say in March or in June, which allowed them to have a bit more time to prepare the budget in a way that accounted for the new context. I should mention also that these numbers exclude the supplementary budget that were adopted before March 2020 when the pandemic was declared. Now, in the countries that did adopt a supplementary budget, so note that it did not always lead to an increase in allocation, with about a third of SBL that actually registered a downward trend, and with an average of 13% less than the initial budget. That is explained by, of course, the reduced revenues and the fiscal constraint that came with that. But despite this fall of revenues being across all countries, a majority of countries did adopt an increased budget. And now we'll look at the content of those revised budget. Next slide, please. Thank you. So unsurprisingly, the reallocations towards the health sector was the most immediate decision for all countries. The graph on the left gives you the increase to the Ministry of Health budget brought by the revised budget law. And that was across all categories: goods and services, recruitments and salaries, with, for example, the payment of bonuses and the extra time for the health staff that was needed. In some cases, infrastructure as well, but not always. And in any case, those reallocation to ministries of health were always focusing on COVID-19 related activities. We'll discuss that later. The other sector that beneficiated very largely from those budgets reallocations were social protection and support to businesses. There was a UN survey of 21 sub-Saharan countries that found that individuals and small and medium enterprise were the main beneficiaries of those budget reallocation, even before the health sector. The pandemic also highlighted the lack of investment in the sector of WASH, water, sanitation and hygiene, and that led many governments to also increase investments in sanitation facilities, in products like sanitizers and soap. Some of them reduced import duties on those goods. Some countries subsidized water bills. So there were really a variety of approaches in the sector of WASH on the budget side. And it's worth mentioning that budget reprioritization, that also happened on the revenue side, with a series of fiscal stimulus packages to ease the pressure on businesses. So these were the main universal, so to say, trends in budget reprioritization. Now, next slide, please. So, of course, if there were winners of the reallocation, there were also losers, and that's what we'll look at now. So at the budget line levels, many countries applied cuts in their recurrent spending through mainly goods and services appropriation, and in particular in what was considered non-essential budget items. So those cuts were sometimes very significant. For example, Algeria's supplementary finance bill announced a cut in recurrent spending by almost half. And some of these obvious cuts were about travel, sports, entertainment, which of course had become quite superfluous in the context of lockdown and closing of borders. So that was the case in Cabo Verde, Ghana, and Lesotho. Again, to just name a few, but there were many more. So it's now what's important to note is that some social and human capital sectors were also negatively impacted by those budget reallocations. So education was often a big loser. And that's particularly true in the context of schools closing for months at a time, or functioning under measures of social distancing, which should have led to additional cost to ensure the continuous education services, and instead very often they suffered budget cuts. You can see on the graph on the bottom left the change in budget allocation to Ministry of Education before and after the SBL. An area that wasn't clear was capital expenditure. That's the graph on the right. So it was often targeted because they provide the advantage of they provide easy access to large lump sums for countries which are financially constrained, and therefore decide to either cancel or postpone public investment projects. So this should, however, be done carefully in order to avoid sunk costs or longer term consequences, for example, by avoiding cutting into maintenance or also keeping in projects that are already ongoing, or also keeping in projects that have low cost but high economic return. So there's really a trade-off here in these CapEx allocation cuts. And you can see that quite a few countries actually increased their CapEx allocation, either to increase allocations to WASH and health, and also in some cases as a way to maintain some economic activity and jobs. In the case of budget cuts in general, we did see quite a few cases where budget cuts were applied, so to say, across the board, in the sense that almost all ministries suffered budget cuts, and often with no obvious disaggregation or justification, at least not in the budget documents that were published. And this can be a sign of limited prioritization, limited planning, and it does come with a risk of impacting essential service delivery, such as education, as I mentioned. And that's another issue worth pointing, is that there was often a lack of publication of basic budget documents during these supplementary budget reallocations. Most SBLs were published either with limited background documentation, very limited information regarding in-budget movements. There were almost never any citizen budget. NTEFs were often not included or revised, and that really limits the parliamentary and also the public oversight of the budget, and also it complicates any form of ex post analysis for ministries when they want to assess the effectiveness of the reallocation that took place, and whether they were aligned with policy priorities. This being said, there were a few examples of really good practices. I think it was in Nigeria, where a couple of subnational governments, subnational states did publish citizen budgets or conducted citizen engagement meetings. And of course, we should keep in mind that there was a big time issue constraint. But this is something to remember for the future, to ensure the quality of budget reallocation, budget revision, transparency, and traceability should be key. Next slide, please. So still related to the issue of basic services being impacted during those reallocations, that's something that was mentioned during a couple of previous presentations. Even though there was a huge movement of reallocations toward health, it was always towards COVID-19 related activities, and in many cases, other non-COVID related health activities were actually impacted, and so in some cases, budget reduction. There was a series of surveys conducted by UNICEF and WHO, which reported a very large impact of the pandemic on different aspects of primary healthcare, like sick child services, antenatal care. There were very important disruptions on routine immunization and also in the management of malnutrition. And this highlights the need to reinforce these services rather than apply cuts. And that should be kept in mind when we discuss reallocation towards health in the future. It should not come at the detriment of other health services. And that's obviously very related to the question of vaccine financing. So there is, of course, a need to increase financing for the vaccine. My slide actually refers to the World Bank study that was mentioned earlier by Caitlin. But beyond this increase for COVID-19 funding, we also start to see in some countries some cuts in the overall non-COVID related health budget in 2021 and in coming years. And this is in part due to cuts in donor funding, that has to be acknowledged, but it's also related to budget priorities and choices to be made given the constrained fiscal space. I think it was Mr. Kaba from Guinea who referred to this in his intervention earlier. So to summarize this idea, it's just that future health budget and future budgets in general should really integrate the investment needed for the pandemic response, of course, but not at the expense of other health essential services, which is something that happened in 2020. I'll move to the next slide, please. So a few key lessons on this story of reallocation. The first key point is that the tracking and the transparency of reallocations was really insufficient. Not all countries, as I mentioned, produced detailed supplementary budget law. Very few published the revised MTEF, and it really limits the tracking of not only COVID-19 expenditure, but also the alignment between budgeting and service delivery. The second point would be that the lack of targeting, there is a lack of targeting in budget reallocations, and that comes with the risk of impacting basic service delivery. And it's true that countries do have to apply budget cuts, did have to apply budget cuts in a very short amount of time. But when doing so, the question is not only where should the money come from, but also where it should not come from. And that's almost as important as the question. And I think it's where it's interesting to reflect on how budget systems can be reformed to respond better to emergency budget reallocations, because that's the third point. The fiscal constraints and the uncertainty are not going to go away anytime soon. That's a reality that will be still true in the short and medium term. And so there's a need to reflect on how budgets can become a better tool to deal with uncertainty. So there's already some discussion happening on how mechanisms can be developed, for instance, by making budgetary appropriation contingent on specific economic or emergency scenarios that already exist in some cases. There's some interesting discussion around differentiating between core and non-essential allocations during the budget preparation already, during the phase of the budget preparation, rather than already in the midst of the crisis. Or very simply, the importance of existing tools like contingency funds, which provide, as we mentioned, a buffer, and they're allowed to buy time to revise the budget in a more informed manner, and that can be extremely useful. I'll just give a quick example on the use of flexible budgets. Senegal included in their 2021 budget the creation of an additional reserve appropriation, and they predefined some non-priority items for which the allocations get unlocked only when the revenue collected meets a certain level and when predetermined action are already completed. And I think that's a really good example of how budget can be used to account for this uncertainty. Next slide, please. So I'll now move to the topic of reallocation toward vaccines. So we saw that very few countries initially included allocation for the vaccine in their initial budget. In 2021, most nations increased their budget to support a much needed economic recovery, but they did so under high fiscal pressure, very deep fiscal deficits, and that in part explains why a large number of countries made the decision to rely mostly on donations rather than resorting to mobilizing domestic resources and looking at bilateral agreements. And as we mentioned in previous presentations, there was also a lack of clarity on the prices on the vaccine, on the availability of the vaccines. And so some countries reported difficulties to budget accurately, which also explains the lack of inclusion of vaccine allocations in initial budgets. And what we see now is a trend toward more and more bilateral agreements. So similarly to 2020, we're starting to see mid-year big movements of reprioritization, reallocation towards the vaccine. First, a number of countries had to open emergency credits early in the year to provide down payments required by COVAX or by bilateral agreement and vaccine producers. And more recently, several countries also started to adopt revised budgets in response to the need to create and sometimes to increase an already existing allocation. That was the case for Nigeria or Senegal. And as I'll repeat what was said, there is also a movement of financing going towards vaccine research and production, like in South Africa or Algeria as well. On the slides, I included a few examples of sources that I came across when looking at budget reallocations in 2021. So countries resorted to capital expenditure, some used remaining cash balance from 2020, some reprioritized existing loans. We also saw example of contingency funds being opened for that. And otherwise, the latter provides a reserve cash for countries who want to rapidly provide down payments. And the same risk exists as previously mentioned. Large reprioritization, when they're done very quickly, can be done at the expense of essential health or other social services. And like last year, there is a lack of transparency regarding the movements of funds towards the payment of vaccines. We've seen a lot of countries who announced the procurement of vaccines early in the year, but without necessarily providing information regarding the source of the spending. And I'll now very briefly, I'll try to accelerate, talk you through a few examples of countries and how they budgeted and procured for the vaccine. Next slide, please. So the first case is Botswana. So Botswana did include an allocation in their initial budget, which was adopted in June. And what's interesting is that despite adopting a budget with an allocation for the vaccine in June, they actually presented to the Parliament in July a request to revise the health estimates because according to the media, it was reported that by July they had already dispersed or committed 70% of the initial allocation. And I think it illustrates quite well the difficulty that countries have to accurately assess the cost of vaccination programs and the need for budget flexibility on that front. So the supplementary budget was approved in August with an increased allocation for the vaccine purchase and distributions. And regarding the source of financing, Botswana decided, like they did in 2020, to use capital expenditure allocation. So they announced the postponement of a large number of programs and projects that were planned for 2021, sorry. And it's interesting to note that they did only postpone projects which had not yet started so as to limit the risk of sunk costs. Next slide, please. Thank you. So South Africa did allocate budget to the vaccination program in the budget that they adopted mid-year. And I'll accelerate a little bit, but what I wanted to point out in this one, which I think is really interesting, is that they did plan for the uncertainty and the difficulties related to reaching accurate cost estimate for the vaccine program by introducing some flexibility. So what happened is that the Treasury significantly increased the contingency reserve by adding an extra 9 billion rand, to be used in the case where the vaccination cost went beyond the initial allocation, which is not the case yet. But it's it illustrates very well this idea that it is hard to assess the cost, and you should plan for some flexibility. And I'll also note that they did include the vaccination cost in their MTEF for the coming years. Next slide, please. So lastly, we'll look at the case of Senegal, which is one of these countries which did not initially allocate for the COVID vaccine in their initial 2021 budget, which was adopted at the beginning of the year. They did manage to initiate the COVID-19 vaccination program thanks to an early purchase of doses from China, and so they bought these vaccines early in the year thanks to emergency environments. And they did later on introduce an allocation for the vaccine with a mid-year supplementary budget. And they, as was mentioned several times before, they also announced their intention to invest in vaccine production, although this will mostly be funded by donors. And it's not clear yet how much of a contribution the government will make to that. I'll stop here. Thank you very much, everyone, for your attention. My apologies, it was a bit long, but I'll now leave the floor to my fellow presenters.
Thank you very much, Claire. That was very interesting, and don't worry, nobody noticed that you went a tiny bit over time. This was very good. Andrew, over to you.
Thank you, Philip, and thank you to Claire as well. Good morning, everyone. It's a great pleasure to be here, and thank you for including me. I want to start by just responding to a few things that Claire has raised, and in that many of the themes sound familiar. And across the OECD's 38 member countries, hearing, for example, that in-year adjustments were insufficient on the continent was very much the same across the OECD membership too. That contingency funds and reserves were also insufficient and simply not there to the extent to fund all of the responses to COVID-19. Probably the only exception to this was Norway in terms of having access to very, very large reserves. And in keeping with Claire's observation, the most frequently used tool to give to action increases in funding were supplementary budgets. And not only did every OECD country use a supplementary budget, they used multiple ones in terms of either finding that the first supplementary budget was either insufficient, or that new information had changed the kind of public services that would be required to help respond to COVID-19. Perhaps one thing that stands out is the fact that balance sheet, what we would call as balance sheet responses, such as guarantees or loans, access to credit to keep the financial sector working, was a strong feature with all of the measures that OECD countries put out, to the extent that these responses in terms of guarantees and loans were of an equal size in round figures to that of current expenditure for public services. As a result of not having the reserves, that meant that the additional expenditure was funded from debt. So on average, the increase in budgets was approximately 20% in terms of a difference between 2019 and 2020, and increases to public debt approximately on average 20% as well, reflecting the fact that the source of that money for the increase in funding came from debt as opposed to other sources. One of the interesting things about taking supplementary budgets forward to parliaments for approval during the pandemic and the early stages of the pandemic was that parliaments weren't always sitting. So at a time when the greatest increase in terms of being much larger than an annual budget was taking place was a time when scrutiny from the opposition was not always available. For OECD countries, this meant that parliamentary budget officers and independent fiscal institutions played an important role of providing that scrutiny, and in sometimes actually calling out government for the level of transparency to be maintained in the way in which projections and forecasts have been put together. A number of these institutions also provided independent costings on how much some of the initiatives being proposed would cost there, which provided a perspective in addition to the government's own costings. So while there was legislation for supplementary budgets, of note, a supplementary budget was one piece of legislation. It might have been repeated if there were multiple supplementary budgets, but the largest area of legislation that was passed during the COVID period was actually on its implementation in terms of changes to either labour laws, work environment, purchasing requirements. These were the aspects to give effect to a supplementary budget, as opposed to needing to change budgeting laws themselves. So while there was a considerable increase to the health spend, as Claire pointed out, other areas such as education did not always increase through it. And what's of note is that with the exception of Switzerland, which is the only country that increased its expenditure across every category of current expenditure in terms of education, health, justice, housing. The other OECD countries had all reallocated or had a decrease in other portfolios to some extent. This might be in, say, Austria for education. It might be Chile, which cut a number of areas, including a decrease in defense, economic affairs, public services. Also, a great number of OECD countries reduced the expenditure on foreign affairs and on cultural events during the pandemic period. The other universal expense that decreased, but was probably from no active decision by government, was interest on debt, and that's principally because of lower interest rates applying, and that the increase in debt, that increase in the servicing of it, has not yet kicked in the actual current budget. It'll be in the next year. But on the whole, reallocation, not only within an appropriation, but also across portfolios for every OECD country except one. So it's with this too, of course, a number of countries are federal in character rather than unitary, and has seen increase in transfers to subnational governments, particularly in countries such as Belgium and Germany, and in instances such as Australia, where agreements had been reached with the states and territories for the funding of health expenses, in terms of basically creating confidence or the certainty for those states to know that there was a backstop for the funding to occur. Now, what I found really interesting with Claire's slides was her observation that there was limited tracking from the additional expenditure in Africa. And have got to say that when we went out and surveyed some OECD countries, found that performance criteria or performance indicators were not high on the agenda at the early stages of the pandemic. Identifying performance metrics and understanding how the additional expenditure was to be used was something that had an increased focus after the emergency stages of the pandemic. And in particular, helping to inform targeting down the track in terms of how to better focus the additional expenditure. But very interesting that during the emergency response, all of the focus that you might expect to see from performance budgeting frameworks was not the priority. The priority was the design of the interventions and the approval and distribution of cash to help implement them. And only afterwards was there a focus on that performance criteria and assessment of potential impacts. Now, with most cases, there are exceptions. Canada and Iceland, for example, are notable exceptions for conducting impact assessments on the additional expenditure. Now that targeting of expenditure and looking at effectiveness is receiving greater attention, spending reviews or expenditure reviews as an increasing activity across OECD countries. All OECD countries, apart from 2, undertake spending reviews. So it's a widespread practice to look at the base of expenditure, the expenditure that was approved in previous budgets, and to help overcome the marginal bias that exists with a budget process. But that focus that exists across the OECD membership is now increasing, particularly after budgets increasing from COVID-19. And we're seeing that apply with a greater number focusing on an annual spending review process to access that on a regular basis and go back and keep examining it, but also to look at effectiveness. And this means that spending reviews differ from how they were used following the 2008 global financial crisis. This is about whether the interventions are effective in order to identify higher priorities. Now, priorities can be a subjective term, as we all know. Priorities refer to those of the current government. And this means that looking at the base of expenditure can often contain priorities of a previous government that just haven't surfaced through in the examination of a budget process, which is focusing on new expenditure. So effectiveness of delivery and prioritization for the current government's policy agenda are 2 crucial aspects of that. Now, what does that mean in terms of where the focus is on budget frameworks as a result of being tested through COVID-19? 3 aspects here: medium-term expenditure frameworks in terms of looking to the medium term to try and have better information and to inform resilience and the path of expenditure. Development of fiscal risk frameworks in terms of helping to improve that resilience, and spending reviews or expenditure reviews to look at the base. In terms of Claire's comments on vaccines and the health sector, some observations of what we're seeing. Firstly, an emphasis on prioritizing primary health care in terms of being critical to the longer term resilience of the health sector. Unlike Claire's comment that identified that areas such as training have been deprioritized, training has been identified as an important enabler for that longer term resilience and to actually keep the priority up there, along with the promotion of disease prevention as well in terms of 2 activities. These are observations that my colleagues in our health department have produced in a publication that I can share a link on for it. And the targeting in the health sector has very much been on risk sectors that are involved with the implementation of COVID responses, and placing greater attention on disadvantaged and vulnerable groups in the community. With there, I'll stop and allow my colleagues some time. Thank you very much.
Thank you so much, Andrew. I just want to move straight on to Ike if possible, so that we can keep to time.
All right, good afternoon. So I'm just going to, as you rightly said, step in for DG, just to make a brief comments on the presentation by Claire, which I think actually captured most of what happened in Nigeria, for instance. So for us, for the 2020 period, the budget had to be revised. So it's the entire budget that was revised, and the key focus was Nigeria is an oil producing country, and one of the key things that was affected by COVID was the oil sector. So the shape of the budget had to change entirely. So we had to like revise the entire budget. But the focus was now to reprioritize and focus on health and other sectors of the economy that were being impacted by COVID. So the health budget was actually increased, especially for the capital budget. And also there was a provision, there was intervention funding, focusing mostly on health, but also for other affected areas such as WASH, social protection, transfers to sub-nationals, and things like that. So we try to keep other key health provisions as stable so that, especially for the primary health care, so that there are no disruptions for financing for those sectors. Mostly what we experienced was disruptions in terms of the operations itself, given the restrictions to deal with the impact of the COVID. Okay, so total budget largely remained the same. The cuts were based on non-essentials across all MDAs. So, not focusing really on any particular MDA, but just looking at what we can do without. Because one of the key things that happen is that you see that there was already a financial constraint, then coupled with the fiscal impact of the COVID. So the focus was on non-essential across all MDAs, but the health sector actually got more funding given the extra allocations to those health. So basically the deficit had to increase, and we actually breached the local threshold of deficit to GDP at that time. So the key challenge really was just to implementation, given that the reallocation was going on at the same time when the budget was already being implemented. And so for 2021, it was the same with what Claire, has rightly presented. For us, we had to go for supplementary budget, and the idea was to provide for COVID vaccine, which wasn't really there, at the point when the budget was being, approved. So we went for supplementary budget, and part of what we, provided there was, for funding of COVID vaccine, and but before the supplementary budget could be passed, there was need for, deployment of the donations, which Nigeria was already getting from COVAX and other donors. So we had to quickly source for funding through a general provision that, covers immunization. So we're able to continue deployment of COVID vaccine, even before the supplementary budget was eventually passed. But key consideration for the supplementary budget were actually, the sort of disruptions it could cause to the fiscal plan for the country. So how do we deal with issues around raising, the fiscal deficit further? Issues around if we are able to deploy additional vaccines, if we eventually, procure more, and given that we already have large donations coming in. So, but eventually we had to, make provision for new procurements of, in terms of COVID vaccine and its deployment. So that's exactly what we did, and the way we have planned it now is that it's going to be a one-off procurement, but then the deployment will have to continue even into 2022. So it's not going to be a once a one-off supply kind of. So we start taking it in as the need arises. So that's basically what we did for Nigeria, just for the sake of time. Also, in the medium term and the long time, we're also looking at local production of vaccine as well. There was the provision as part of intervention in 2020, which we're still trying to deploy into trying to support local production of vaccine. And then we are also lucky that we currently, supported by Gavi and some of our partners like Bill and Melinda Gates Foundation, the immunization in Nigeria is actually being strengthened. So it is something we think if COVID becomes a routine vaccination to me, we can actually just factor it into the already existing strengthening process and then just make it a routine process for Nigeria. So other than that, I didn't think there were too much of disruption in terms of funding for other key sectors. The key area we think is that it has affected our fiscal balance, which is in terms of increasing deficit as a result of the impact on revenue. Thank you.
Thank you so much. That was really interesting. I have sort of half an eye anxiously cast towards the clock, but I want to give people an opportunity to ask questions. Is there anybody who wanted to come in on the discussion or ask any questions of the presenters? I'm just looking at I don't think there is anything in chat right now that I would need to pick up. Mark, I also just wanted to quickly check with you, since South Africa had its brief moment in the sun in Claire's presentation, if there was anything that you wanted to add to the reference there that was made to you. But no need if you feel that this was captured well. Okay. That's great. Then let me quickly abuse my privileges really quick. I'd be curious in like a minute or so if Claire and Andrew, if you could say a little bit about particularly the vaccine aspect of this. And what it is that you were seeing, that you were able to see, because of course it's much more difficult to look at budget figures for something that is fiscally speaking actually a really small item in terms of spending. But I would imagine that there's actually going to be a pretty big difference in the way that this is going to play out between the OECD countries, which, as I think Andrew correctly pointed out, found the fiscal space to be very liberal spenders on all sorts of things related to the pandemic, and are by and large not going to have any trouble funding the vaccine rollout at the risk of default or anything even close to it. Whereas I think for a lot of countries on the continent, this is probably a much more hefty charge on the budget, as of course we've been talking and thinking about throughout the day. Claire, if you want to go first.
Yeah, I'll go first. Well, the first thing I should say is that in terms of what I saw, I did not see that much because, as I mentioned during the presentation and Andrew, pointed at it as well, the issue of tracking and reporting is a real one. And so very often we see through the media or through public declaration that there have been allocations to the vaccine. It does not mean that they appear very clearly in the budget. So in that sense, it's actually quite difficult to assess exactly what burden it represents on the entire budget. In a few of the supplementary budgets I went through, we know that funds were reallocated towards the vaccine, but we don't necessarily know exactly how much and where they were taken from. It's usually mentioned in presentations to Parliament. But this is something where I would actually need to speak directly to representative of the countries. So that's one of the probably the main point I'll make, is that in terms of transparency and traceability, it's definitely a fairly big issue. And something that was quite obvious was that it definitely is easier to track when budgets are presented in programs. They tend to appear in sub-programs, and that makes it easier to track. When it comes to funding and finding the resources for it, it's starting to sound like the international organizations like the World Bank have a big role to play. In the most recent declarations that I could find, financing through the World Bank was definitely a big share of the lion. So yeah, that would be my 1 minute comment to your question.
Thanks very much. That's very helpful. Andrew?
I'll struggle to stay up in a minute, but I'll do my best. On the vaccine aspect, we saw with OECD countries that even though the vaccine sum in relative terms is quite small, as you rightly pointed out, there was not a lot of associated costs, whether that be with protective clothing and equipment or other health equipment such as ventilators, where those costs were higher and were as a result of COVID-19 rather than the vaccine necessarily itself. What we did see instead was non-financial aspects go through, such as relaxing public procurement requirements around tendering and around processes, how they would normally be prescribed for either faster access and the extent to which this was on a temporary basis or had rights to be extended vary across countries. What we are seeing, though, in terms of the expense, though, with these associated costs from the vaccine, are things like temporary facilities for administering the vaccine. Pop-up locations for administering the vaccine, as we've seen in Korea, or increases in ICU beds, as we've seen in Germany. What's interesting is that in some cases, governments have provided incentives to the hospital networks to help increase the speed of implementation. So a tangible example would be in Germany, a 50,000 euro placement for every additional ICU bed there as part of helping incentivize a fast response. What I don't have for you, though, is an example of an incentive that applied directly to the vaccine, more the associated expenses there, but much greater than the vaccine itself in order to give effect to the vaccine.
That was actually a pretty good minute, I would say, because you didn't say, Andrew, that immediately, as is of course typical of Germany, this led to allegations of a corruption scandal where hospitals were suspected of having designated ICU beds as COVID beds when in fact they weren't.
I've left corruption out of all my comments today.
I wanted to come back to Nigeria for a second, because you've already spoken about your thinking around the vaccination efforts quite a bit and how that featured in your decision-making, vaccines versus other costs on health. Instead, I wanted to ask you, as you're now thinking about, future budget exercises and exactly along those lines that you just mentioned for how this is going to go into 2022, as a budget office, do you feel that you have all of the information that you need to take the decisions that you want to take? And what is it that's most useful for you in terms of data analysis, inputs that you're getting from other parts of government and so on? And in part, I'm asking this because there's so many international organizations represented at this meeting today who would love to take instructions and being told what to do. And so if there is anything on your mind right now, then I think this would be very interesting to you.
Thank you very much. Really, data, as you said, has been a big issue for actually making decisions. We've been able to join kind of the sort of a committee that is kind of managing this this COVID-related development for Nigeria, and they hold monthly meetings which we participate in. But yeah, as you said, the first is the what is the direction? What's the focus around how this COVID interventions will go, or the disease itself? What's the direction? What's the thinking globally as to, is it going to be a short term? Is it going to be something that becomes? So in the last meeting of the committee, there are a couple of people suggesting, especially non-government actors, suggesting that these are times that we have to really start thinking about making it one of a routine exercise, so that we don't first have it responding on ad hoc basis, and two, that it doesn't now take off efforts and resources from other sectors, other aspects of the health system. So but as a budget office, we're still looking at that, as in where do we need to place this vaccination for COVID? Is it something that has to be like an ad hoc thing, or is it something that will become a routine? But as I said, with efforts from our partners, there are really key strength in terms of other routine immunization processes in Nigeria, which I think, if eventually it becomes a routine thing, then it will just be a matter of increasing our efforts in that direction and finding a way to, take in the additional resource requirements. Yeah, but for now, data, in terms of the part of the pandemic is really critical. Thank you.
Yeah, thank you very much. I think this is clearly an issue that resonates a lot, and that is going to keep us busy for quite some time yet. Clearly, there isn't going to be an Africa-wide vaccination goal that is going to be achieved without Nigeria. So there's a lot of importance attached to this. But at the same time, it is really hard to predict how this is going to go on. Danielle, I think I've overstayed my allowance a tiny little bit. So before I hand it back to you, let me thank our three contributors for excellent presentations or remarks respectively. This was a really useful discussion and something that is, like I said, is going to keep us busy for quite some time yet. I think Danielle and Claire, the next stage for this work at the CABRI Secretariat is to try and dig deeper into the question of budgetary allocations for the vaccine rollout and try and get more information than we've been able to obtain at this point in time. And it was, I think, really encouraging to see how the issues that we've been hearing in the previous sessions and how this sort of all adds up to something that at the end of the day needs to happen through the health systems of countries, not just probably not even primarily the central governments, but subnational governments and the extraordinary, in every sense of the word, efforts that are going to be required to continue this work on the vaccine rollout. So probably we haven't been able to solve anything, but have certainly learned a lot. And that's going to be it for today. It's definitely not going to be it for the foreseeable future. So expect to see more from us going forward on this set of questions. Ike, Andrew, and especially Claire, thank you very, very much.
Thanks, Philip. Thanks, everyone. Yeah, so I've already gotten Claire to start looking into some of the reallocations to vaccine programs. Just, as she said, not very much information available yet. So for me, thank you very much. I'm going to hand over to the Executive Secretary, Neil Cole, for some closing remarks. But thank you, everyone, for your participation today. I thought it was a really useful session. And yeah, great. Thanks, everyone. Over to you, Neil.
Thank you, Danielle. And just let me thank all the participants, and especially those that have remained on the call. I know that many of us are feeling quite zoomed out, and I was suggesting to the team that maybe we should include some entertainment, like a musician halfway through the program, just to keep the energy levels up. Let me use I suppose the last 30 seconds or so to just say the following, and this is certainly what I take out of the discussions we had today. There's the issue of capacity to administer. Costing and planning is going to be critical, especially with domestic resources and how that aligns with external support. We're certainly excited about developing local vaccine and manufacturing capacity, especially what that means for Africa going forward in terms of the production of pharmaceuticals and the contribution towards research and development. Integrating these cost estimates into annual budgets, and maybe importantly medium-term budgets, and then looking at the impact that this has for health budgets going forward. As Philip has said, I mean, there's a lot that needs further unpacking, not only in terms of the challenge that we have spoken about today, but also what this all means for health budgets going forward. CABRI will certainly and increasingly focus on bringing to these types of dialogues the issues of efficiency and effectiveness of health spending, and future dialogues will be looking at the whole issue of how do investments in health also better prepare the African continent to deal with future epidemics and pandemics. I look forward to, and certainly the team from CABRI look forward to future collaborations with UNICEF, WHO, the World Bank, CHAI, and others that were part of this policy dialogue, and collaboration as we make progress towards reaching population immunity. If we were all together and we had flown to a destination, the closing remarks would have ended with safari in Jema, travel safely. But I suppose it's more relevant for me to say Salaniga Kushle, which is in one of the South African languages, stay well until we meet up again. Thank you very much.